if we can go live and do whatever else we need to do. You'd think I'd know by now. Right, morning everybody, and welcome to the right on cue, interrupted by my phone ringing. Apologies. Morning everybody, and welcome to this meeting of the Board of Directors of Lincolnshire Partnership NHS Foundation Trust. My name's Kevin Nokia. I'm the Trust Chair. Now, it is our practice to start our public board meetings by hearing a patient story. And this morning, I'm absolutely delighted that we're joined by Ellie, who is Jess's mum, and Jess is one of our CAMS service users. So without further ado, Ellie, I'm going to hand over to you. And thank you very much for taking the time to join us.
Oh, it's a pleasure. Thanks for having me. Okay, so I'll just start from the beginning. Jess, last year, so 2021, just over the Christmas period, 2020 going into 2021, January, lockdown, everything else obviously, and my daughter just was down, depressed, whatever, like many teenagers. And towards the beginning of the year, just started to notice changes and a weight loss that had obviously been occurring for a while, but I was not, didn't notice that, and decided to go to the GP. Called our local GP, who was great. We were asked to come in straight away, which we did, and our GP referred us. We did all the checks and things on Jess, and then referred us straight away to CAMS. And I think it was possibly a week, and we had a phone call from the team at CAMS, and just saying that we'd been referred and were we happy, and absolutely. And I think a few days after that, we then had a call meeting with myself to sort of hear about the background, and then with Jess. And I think that was a positive experience. I think she felt so pleased to have some help at last. Not that we kind of knew she needed it, but that's what happened. And we were given some sound advice then, actually, just over a telephone call about eating regimes. In the meantime, obviously, I'd sort of researched a bit of things and realised what we sort of needed to do, but that was all backed up with what the team was advising us to do. So from that point onwards, we kind of changed. We made sure that Jess was having meals and all the rest of it, and we knew we had a meeting. CAMS had arranged a meeting for 3 weeks later, and that first face-to-face meeting was up in Lincoln, and at that point they obviously assessed Jess and did observations, whatever was needed, and felt that she needed to be hospitalised. That was obviously quite shocking for James and I. We didn't really realise that it was that bad, and that was, I mean, they did everything as well, and by, yeah, that was all fine, if a little shocking, but that's not the system's fault. So then Jess was admitted into the hospital in Lincoln General Hospital. I mean, you can ask me about, we basically live near Stamford, and so I was saying, oh, could we go to Peterborough because that's a bit nearer, but I understood that obviously that's a slightly different trust, and we'd already formed this nice relationship with the team, and thought, oh, I didn't want to, none of us wanted to rock that boat really, even though we'd only met the once. But that was obviously it was quite a long journey. It was completely away from where we live. Anyway, that was that. Jess was admitted, and that process started. And I'd say that's the only issue that in the hospital, Jess had said that that's the only thing she felt, that she didn't really know what was happening, and she was sort of in a ward with children who'd broken their legs, and the nurses, as gorgeous and lovely as they were, kind of when it came to the food, were just, because it was an eating disorder issue, the food was probably a problem, Obviously she just had to jolly well eat, but ultimately I'd say that if she just felt a bit like the nurses there was lovely, as I say, they weren't quite on board with what the needs that someone with an eating disorder perhaps has, and should that be when they're next to a little baby or someone who's fallen off their bike, or anyway, that's just an observation, that's fine. So that was fun, and the team from CAMHS came to visit Jess and in the hospital, and obviously James and I went every day. They were brilliant at feeding back. We had immediately the next day, I think we had a meeting with them online. They came up to the hospital. We were made aware of what was to come, I think. Then Jess was released from hospital, and from then on, which was I think the beginning of sort of slight blur, kind of middle of March 2021, and then we started on the road of sort of therapy, and as we had family-based therapy, which, considering we're a divorced family, was brilliant for us, absolutely. And I think that's for us, it's worked really well. So Jessie has a good relationship with both of us, and we all get on brilliantly. And so James and I were able to, I guess, really work together for Jess. We both came from the same hymn sheet. We both knew what we had to do, kind of a bit hard in some ways, but there wasn't a good cop, bad cop, I guess. We were both just on the same page. Lucky us. I kind of think we were probably more functional than perhaps many families. From a dysfunctional sort of family, we were probably more functional than maybe a family of four. So I think my feeling is for us it works so well, but I can see if we were a mum and a dad and two children, I think it's probably a harder, that's probably more difficult. It just really did work for us. I'm really babbling, sorry, just ask me a question. So Jess, then we had Jessie had some one-to-one therapy, which I think was, none of us had been through anything like this, so I think that was helpful, and we would have at least weekly family meetings. Obviously there were ups and downs in the process, and that's not from the service that we had, that was obviously just Jess's journey, and looking back now, I guess that's how it goes. But obviously we were not aware of actually what was to come. I think we just thought, gosh, your weight will be restored, and then it will be okay, and it sort of isn't okay. It's an ongoing process, and the more questions that we asked, I think the more we were assured that it was quite normal, if you want to say that. What we were going, I don't think the team were worried that anything was not perhaps what they've seen before, or this is how it goes. But we were also made to feel, that wasn't to say that we were following a process. They made us feel that it was definitely our journey. Yeah, I have to say, I can't. The team were so good, really good. So that continued. Jess's weight very steadily has just restored. We've just been discharged from the services actually just at the beginning of the month, so that's really good. I think the ups and downs, I think sometimes as a parent you panic and you just want to call somebody to fix it. Sometimes I think we did that with you guys, and then you couldn't fix it because you can't, and it doesn't work like that, but you're disappointed that then you're not getting any action, and that's frustrating. But in hindsight now, I understand that's just how it works. There isn't a quick fix. There's nothing that you can't just make it okay. I think that's yeah. So I think that I think that I have had other friends who have been through the system and really don't seem to have had the positive experience that we've had, and that's because obviously their family situations might be different, many more children, they're together or whatever. and it feels like it doesn't feel like a consistent system from what I hear of other parents. But my personal experience and our family experience and Jess's experience is, yeah, great. And we've come through it, and we've got places to go if things become difficult for us moving forward. And I feel confident that I know we can do that. So yeah. Yeah.
Thank you.
That's okay.
Sorry, thank you, Ellie.
That's okay.
Are you okay if I and perhaps board colleagues ask you a couple of questions?
Totally.
Is that fine?
Yeah,
before we do, Eve, is there anything you want to add to what Ellie's said?
No, what I'd just like to do is thank Ellie for coming today, and the brief we gave her was to be really honest about what it felt like to receive our services, and I feel that that's what the last 10 minutes has been. So yeah.
Thank you, Eve. And Ellie, I don't underestimate how difficult it is to come even on Teams and to say the things that you've done in public. And I really appreciate your honesty and your courage. I think is not too strong a word to come and talk to us in the way that you have. So thank you very much for that. Can I ask you, before I open to colleagues, can I just ask you a really simple question, and that's, what could we have done better? And not just LPFT, not just my trust, but what could the NHS have done better? Either to help your daughter or you and your family.
I feel that that the team of practitioners, the team that we had are so fantastic, and I feel that they are. I know this is just so topicky, isn't it? But you can tell it's so under-resourced, and they're kind of having to do quite a lot of things, I should say, admin maybe, and things that I think, gosh, your time would be much better spent giving it to your expertise and knowledge and care. That's what we want to have, but somebody else doing the sort of nitty-gritty, I think, of an admin is that doesn't need, I'm sure they don't need to be doing that. It would be, yeah, they're great. They're just great. Yeah.
Thank you. I really appreciate that, and yes, I think you're right. Sometimes our and Eve, you may nod along to this. Sometimes our administrative systems are clunkier than we would like them to be, and sometimes it's not that we don't have enough people; it's that we don't have the infrastructure to do the things as smoothly as we would like them to to be done. We recognise that, and we also recognise, and you said, Ellie, that you have friends who haven't had as good an experience as you, and one of my biggest, as board chair, one of my biggest concerns is that we are not always consistently good, and when we're good, we're fantastically good, but unfortunately sometimes we're less than good, and I regret that, and that's our focus as a board, to try and make sure that we've got that consistency. But hear that message very, very strongly. Look, I will open up to my board colleagues now. Has anyone else got any questions for Ellie or for Eve? Let's put her on the spot as well. No, I don't know whether it. Yes, Chris. For a moment then I was beginning to think that my chat had gone silent, or I'd stunned everybody into silence. So, Chris.
Yeah, morning. Thanks for the story. That's just really good to hear that honesty and reflection, and pleasing to hear that things have improved for you and your family. So it was just a comment really, and I think I know there's some of the answer to that, but I just wanted to hear that that's right. Is that you said talked about the staff on the acute hospital when daughter was admitted there, and then their understanding around eating disorders and how best to support. And there's obviously a challenge there because that's not their bread and butter in terms of what they do, but equally there are a number of children that would end up in that environment. So it's what would have made a difference for you. And I know maybe you can just comment on any work that we're doing on that. Yeah, from a family's perspective, was there anything specific that would have made a difference for yourselves, do you think?
I think that and this is my daughter's observation rather than mine, and her being a sort of patient, it was that, as I said, the staff just fantastically lovely, but that when it came to the actual, I think she was sort of like, well, I'm here for an eating disorder, and then somebody comes and brings you a plate of ice cream or something, and I know that just sounds so sort of ridiculous, isn't it? And you know, but I think maybe for young people with that's the reason they're there. It's quite major, and that would just be a comment that I would make. And I totally understand that. Flipping out, that's so hard to. How do you do that? And you can't put a load of eating disorder kids in a ward together. I mean, gosh, glad I don't work for the NHS. It's so hard. It's so hard. Yeah. But that would really honestly only be that's the observation that we had, I would say.
Great, thank you.
Thanks, Chris. I've got Jane next.
Thank you, Chair. Hello, Ellie. My name's Jane Marshall. I'm one of the executive directors in the Trust. Thank you for your story, and thank you for sharing what is obviously a very personal story with us so that we can learn. One of the questions I wanted to ask was around, you said you noticed your daughter lose weight.
Mm-hmm. Yeah.
One of the things we're trying to think about is prevention and early intervention.
Absolutely.
Is there more that needs to be available in your view to help spot problems early, you know, share information? Are there any gaps that you perceive there that we can think about to get into that sort of prevention side of the world? Thank you.
Oh gosh, I guess my feeling is that isn't really your, you know, I think from schools, I think we have to be very aware of those things in a school, but those things can only come from a home environment, can't they? Because it's a kind of bigger picture. You don't just, yeah, it's a bigger picture. So I think it has to be, I think we have to pick up the vulnerable people because it's probably happening to them much earlier than we would ever know. I mean, even here at school, you know, you can see quite young children, and without jumping on the bandwagon and alarm bells going, I think it's probably a good opportunity to just say to people, gosh, you know, your eating can and your mental health can have such a detrimental effect. But look, there's some seemingly quite easy fixes, and I know it's not easy, but actually, if parents were, I don't know, it's a minefield. It's a minefield, but I feel that a lot of the time it has to come from home. We can't always just keep saying, you know, it's the NHS's responsibility, because you want to stop it, don't we, before it gets to the crisis. Before Jessie should never have had to go into hospital. Sadly, she did.
Indeed.
But you want to stop it.
Yeah, I think we do have a role and a responsibility to partner with families, but also other organisations and schools, and we do some of that already. So if you think, as a result of today's conversation, about things that would have made that difference, then I'm sure that it would be really good to hear those. Thank you for answering my question.
Thank you, Jane. I mean, it's a really good question, and one that several of us, I think, would have asked if you hadn't. And I think the thing is, Ellie, if we could spend money, as it were, upstream in preventing those issues, we would get a better return on every pound we spent than spending it when people get really poorly. You know, so I think it is partly our role as a mental health trust to try to, you know, divert people from, putting it crudely, you'll understand why I use this term, more expensive services. You know, so before they get so poorly that we have to admit them to hospital. I think I've got Sarah, who's the trust CEO, next. Sarah.
Hi, good morning. I'm Sarah Connery. I'm Chief Executive of the Trust. So Jane asked my question, so I'll part the question, but I did have a comment. And just to share my own experience, because I did have an eating disorder as a teenager, and it was the love of my family and actually some intervention from my GP that got me through it. So it's something that I do feel very passionate about in terms of getting right for our population. But just to build on Kevin's point about early prevention, I think as well, you know, the experiences that you've shared today within your family in terms of how we connect with United Lincolnshire Hospitals as well, in terms of when people do need, because some people will need the acute services despite putting the prevention resources in. So it's just some assurance really that we are trying to make sure that we're connecting so that families don't see the joins and you get that holistic, well-rounded care at the point that you need it. I'm not saying that we're getting it right. Quite clearly we're not getting it right at the minute, but the ambition is definitely there. So I just wanted to share that as a comment.
Great. I mean, God, that's amazing. If that's, I guess that's a lot easier said than done, isn't it? But yeah, and I know this is a sort of a logistic or a geographical thing, but I know that a lot of friends, and the only thing that we felt was obviously Lincolnshire's a massive county, and you know, I work in Cambridgeshire and my daughter's at school in Rutland, and there's a whole, it's that whole crossover, isn't it? And that's must be a nightmare. You know, we all know it must be a nightmare. And I don't know how that can be. I mean, I don't know how you, but it would feel, yeah, that must be an ongoing problem, and not just with.
We like to draw boxes around things in the NHS, and to a certain extent you have to make things manageable. The challenge for us is how do we make sure that you don't see those boxes, and as you say, it's very complicated and difficult, but that's what we're all here to do, so we'll battle on.
Thanks, Sarah. I've got two more colleagues that want to ask a question or make a comment, and then I'm going to conclude this part of our agenda. So Ananta.
Thanks, Chair. Hello, Ellie. I'm Ananta Dave, and I'm the medical director here in the Trust. I also happen to be a child and adolescent psychiatrist. I've been working with young people for many years. It was heartwarming to hear that Jess has, made a recovery and is in a good place. And also, very thoughtful reflections from you about how, what helped and, how you work together as a family, and also what the comments you made about what could happen in the acute ward. And I was just thinking it's for us to think as a trust and as a system. As Sarah said, we are trying to work together closely, the acute trust, mental health trust, and education sector, etc. But one of the things perhaps we could do is we are having a plan for some training to be provided at system level, and I was wondering, Eve, Jane, etc. When we look at system-wide training for staff, whether awareness around eating disorders for all staff in the acute sector could be put into some kind of an overall basic training module around mental health, so that when young people do get admitted, the staff there are, feel more empowered to support them in the specific way that they need. So that's something that I would like to explore at system level. But thank you for those observations, and all the best to you and Jess in the future.
Thank you.
Thank you, Ananta. Eve, did you want to comment on Ananta's suggestion there?
Yes, just to take that. Just to build on what we're already doing, because I think that system level working is really important. What we're already doing is partnering in particular with Rainforest Ward, which was the ward that Jess was admitted to, and we have a rolling programme of training that's delivered around eating disorders and what that might mean. What Ellie's story's done for me is made me reflect that I want to go back and check how much of that training is done from the point of view of the children and young people who are on the ward, because I think we are doing the training to raise awareness of what an eating disorder is and what the interventions might be. I think Jess's reflections through Ellie were very much about some of the real nuances about, if you're a paediatric nurse, a way you showed kindness is to offer someone ice cream, but that's not necessarily appropriate for someone with an eating disorder. That's a real subtlety that we might not yet be picking up in the training, and I'm going to take that away and check that out, and we might be coming back to you, Ellie, to ask for a bit of input from you and Jess on that.
Yeah, absolutely. And I know that actually Jess would, you know, she's a 17-year-old girl, and you know, she's probably more eloquent than I am at that, and I know she would. I don't know if that's, but she can probably give you. It was interesting hearing that actually last night when we were just chatting about was there anything she wanted me to sort of, and that was that, and it wasn't in a, it was just a reflection, you know, it wasn't that it was, you know, a trauma, or but now she's come through, and the knowledge that she has, that's quite big when you think, it's like, oh yeah, obviously that's kind of rubbish, isn't it, really? Yeah.
Thanks, Eve. Last question, Di.
Thanks, Kevin, and thanks, Ellie. My name's Di Bailey. I'm one of the non-exec directors. Have done quite a lot of work with children and young people with mental health problems. So was really interested to hear, and really relieved to hear actually that Jess and yourself were able to get the help you needed. And from what you said, it sounded as though that help was offered relatively quickly. There weren't any particular long waits, and some of that would obviously be down to the needs that Jess had at that time. Sometimes, unfortunately, people do wait longer for services, and I'm just wondering whether there's anything that, on reflection, you could say to us in terms of, you know, if in between times when people were in contact, or if people were having to wait a bit longer, is there anything that we could do that would make that you know, sort of helpful, really, to sort of, you know, keep in touch, I guess, or
good. Yeah, well, I mean, I think again we're quite lucky with our GP. I guess that was where we fell again. That's just the luck of the postcode lottery, isn't it? But we have a great little doctor's surgery in Castle Bytham. You know, the doctor was, yeah, on it, and lucky old us. So it didn't, but I guess that for some people it probably would, if the services are not there straight away like they were for us, I guess. But then, yeah, I guess it would have to fall to the GP to just keep communicating and saying, you know, are you okay? Don't worry, you know, help's coming. But in the meantime, we're here. Is there anything? I mean, yeah, that would be wonderful, I guess. But easier than done again, I suppose.
I think that's really interesting, isn't it? Because if we're working in that system way, it's important that we don't forget our primary care colleagues and our GPs, and we need to make sure that we work really closely with them, because they are probably the folk that are there sort of on a consistent basis, I guess.
Yeah, absolutely. Yeah.
I'm pleased to hear that you did get a good supportive service from the GP.
Yes, I did. Yeah.
Great. Okay. Thanks, Kevin, and thanks again, Ellie and Eve.
Thank you, Di.
Kevin, you've gone to mute.
I muted myself when I meant to unmute myself. You'd think, wouldn't you, Ellie, after 2 years at this, we'd understand how to use Teams by now.
Don't worry.
Look, thank you very much for giving up your time this morning. Thank you for being so open and honest with us. And thank you, Eve, for coming along as well. Please extend our best wishes to Jess.
Yes,
Ellie. But great. Thank you very, very much.
Thank you. Keep going, everyone.
We'll do our best.
Okay, thank you. Bye.
Thank you.
Bye. Bye.
Bye.
Oh God.
We'll keep.
Okay, I think I've probably gone. I don't.
Well, we're carrying on anyway. So we've got, I think the only apologies we've got, Peter, are from Philip, who's going to be joining us a bit later, I think at 11 o'clock. But other than that, we're complete, are we not?
Yeah, I think Philip is actually with us at the moment, or has been. He may
okay. Yeah, I think he's going from 9:45. Sorry, yes. Philip. Yeah. Do we have any declarations of interest other than those that are normally recorded for the purposes of this meeting? No, let's move on then to the minutes of the last meeting. Does anybody have any comments? Yes, Sharon.
My comments actually on the declaration.
Sorry,
Chair.
I didn't see your C
That's
quickly
fine.
enough.
I just thought I probably should declare a potential conflict on 7.4, which is related to the
Yes.
side-head role and deputy chair.
Yeah. Okay. Look, I think it's fine for you to be present while we discuss that, as long as you're comfortable with that, because your contribution to the meeting isn't going to be determinant, as it were. So I think we'll be fine. But thank you for signalling that. Ananta.
Yeah, mine was about the minutes, and just a very minor correction. I think on page 5, I started in this trust in May 2019, and it says 2021 over there. So just that correction. Thank you.
Oh, we should get that right, shouldn't we? Thanks, Ananta. Subject to that amendment, are colleagues happy for me to sign the minutes as an accurate record of our last meeting? Thank you. We'll move on then to the schedule of actions. There are 3 actions that remain open, a number that have been completed or closed off. Has anybody got any comments on either the open actions or the closed ones? If not, I think they're pretty self-explanatory. Andy.
Sorry, thanks, Karen. Andy Spring, non-exec director. It's just with regard to the last action on the schedule of actions about moving.
The last open one, or
no, closed one, completed.
Yeah.
The culture of autonomy. I just wondered how, as a board, we can be assured that this is actually how it's going to be for our staff. So just how we follow this up. Because what we've done is said that the ET's had the discussion. It's on the leaders agenda for June. Actually, how as a board do we know that we've moved that for our staff, and that's how it is for them?
Okay, good question, Andy. Sarah, do you want to comment on that?
Yeah, I've got a thought in terms of the people surveys, the pulse surveys. They do request people's input in terms of whether people feel they can make a difference to the organisation. So I guess there's a hard metric that we could look at, but it's a good challenge, I think, Andy, in terms of how does it feel for people, which is a bit more nuanced. So possibly need to have a think about what that will look like when it's working well. I don't know whether other exec colleagues might want to share their thoughts, but that's sort of where my head was at.
Chris.
Yeah, I think there's something symbolic about the inspirational leadership event. I think in June that will kind of set a line in the sand, an intention that's publicly kind of declared across the organisation for all staff. So I think that will certainly put a marker in the sand. There's still no getting away though from, we're still in at times command and control structures as the waves of pandemic come and go, and like to do for a while. So there are times we had to step back into that. But we are having conversations with our leadership team around how we can look at the leadership training for new managers, particularly to look at how, because some of our new managers have only worked in a command and control environment as they've joined in the last 2 years. So I think there's a short-term piece through the inspirational leadership event, but then there's some longer term work with training and development that we need to do with all our leaders across the trust.
Thanks, Chris. Peter.
Yeah, Kevin, just following up on, sorry, I'm Peter Ham, the Trust Secretary, just following up on what Chris has just said. The Inspirational Leadership Programme is for all of the senior managers in the Trust. We have the board development session at the end of June, which is looking at similar issues. I just wonder whether we put an action on here for feedback from that Inspirational Leadership Programme to be fed into the board development session at the end of June, and that would tie together all of that cultural, behavioural visioning stuff.
I think that's a good suggestion, Peter. I think, Andy, really good question. I think partly this is not the kind of issue that lends itself to kind of systemic reporting to the board. But I think there is a range of evidence that we can draw on that enables us collectively to take a view on whether or not we've made the shift that we want to make as an organisation. And I think Peter's suggestion is a really good one, is that we take some of that evidence from the inspirational leadership program and bring it into board development. The other thing that we can do, of course, both as execs and non-execs, is observe, and by being with staff in services, we can develop our own sense of whether or not we've made the shift that we want to make. So I think it has to be a well-rounded kind of way of assessing whether or not we're on the right path. It's not something that we can necessarily report to board through a single kind of line of evidence. But thank you. So that's a really helpful suggestion. Peter, you're right. I think it would be helpful for NEDs to sit in on ILP. I go to it and usually introduce and wind up the sessions, but I think other NEDs would be very, very welcome. I've got two more comments, then I'd like to move on. Ananta.
Yeah. Hi, Ananta Dave here, Medical Director. Just wanted to say, apart from the things suggested by Peter, which are very helpful, I think going forwards, I know we have a plan around group as well as individual development. So, but for all of us in senior leadership positions, exec, non-execs, might also be useful to have that individual reflective session, either with somebody independent or peer mentor from another trust, or I think a combination of constantly evaluating our leadership behaviors, apart from doing them in training days, group settings, etc. Perhaps even asking for feedback more regularly from various people affected. I think it's that would be useful going forwards as we start moving on to the next phase, the post-acute phase of COVID.
Thanks, Nanta. Final comment, Tim.
Thanks, Chair. Yeah, just a quick comment following on from everybody else, because the context of this was coming out of the People Committee and a specific example around inconsistency of leadership. So actually, we will pick it up anyway on a broader front, because we've got that inconsistency of leadership as a specific risk line item. So although this was a specific and perhaps pressing issue, it is a broader context as well.
Thanks, Tim. That's helpful. Let's move on. That's a helpful conversation, and thank you, Andy, for raising it and for your agreement around the suggested way forward. I appreciate that. Let's move on then to the Chair's report. Three things, I think, to specifically draw to your attention. I hope the report stands on its own 2 feet, as it were. The first, taking them in reverse order almost. The first is that we're starting to develop a programme of what I hope will be really useful board development sessions that start to help us shift away from dealing predominantly with routine business and start to think about future strategy. As part of that, been discussing both with Peter and with Sarah, reshaping our programme of meetings and having fewer routine board meetings and more board development sessions. So we might end up with 6 formal board meetings a year and 6 board development sessions, which might give us a better balance between what I tend to refer to as kind of routine transactional business and our desire to, particularly in the context of all of the system changes, our desire to get into some rather meaty strategic issues. So more on that, I hope, very soon. The second is to report the appointment of a new non-exec, Chris Wright. His details are in my report. I think he'll be an excellent addition to the board. He was, I think, impressed everybody that had a role to play in the selection process. And then finally, just in time before he has to disappear and do other things, I need to note that this is Philip Jackson's last board meeting, and Philip, I've said in my note, I personally will miss your measured and considered contributions. That's not hyperbole, I will. And on behalf of the board, I'd like to thank you really sincerely for your contribution to the trust over the last 6 years and wish you all the best for the future.
Yeah, thank you very much, Kevin, and just really a big thank you to the rest of the board and also to LPFT for 6 years that I have really enjoyed making a contribution to the organisation and to the board, and I've seen a huge transformation in the organisation during that 6 years, a huge transformation for the better, and the standard of care that we're offering for patients, which is what we're all here for at the end of the day, I think is far better than it was, and it's far better targeted, and I hope I've made at least a small contribution towards that, but it has very much been a team effort, a huge team effort, and I think the board has always worked really well as a team, and I'm sure it will continue to do so. With the approach that everyone has, and the aims and objectives of the organisation, and the new culture within the organisation, which continues to go from strength to strength. I think that things look really positive for LPFT in particular. The way it's playing into the system as well at the moment, I think is very important, and it's very influential. So just a huge thank you from me really to everybody for the the time that I've been on the board. That very much enjoyed it. It's just a shame that the last 2 years we haven't really had very much contact with each other on a face-to-face basis, but nonetheless I think we've still managed to continue to deliver the aims and objectives of the organisation and improve patient care across Lincolnshire. So thanks very much to everybody, and all the best for the rest of the board and the organisation for the future.
Thank you, Philip. And on your almost your final point, I've been chair for a year, and I haven't met you in person. I only know you over a screen. So at some point after you've gone, and when life properly returns to normal, let's make sure that we meet up and that we're not strangers.
That'd be great.
Thanks, Philip. And I have to say goodbye to somebody else as well. So as noted in my report, this is also our medical director, Ananta Dave's last meeting. So Ananta, I'd like to say thank you to you as well for your really significant contribution to the trust. I know you're going on to even greater things elsewhere, and in the Black Country, and we'd like to wish you all the best, and say that your new organisation's gain is very much our loss. So thank you very much, Ananta, and all the best for the future.
Thank you very much, Kevin. I'll miss LPFT, and it's been a relatively short time, but a very intense time, and it's brought us closer together, and I will miss and want to keep in touch with some of the people and keep up the relationships, the good working relationships that we formed and friendships throughout my time here. Thank you all, and all the very best for LPFT. I think it'll go far.
Thank you, Ananta. Thank you very much. Has anybody got any questions or comments on anything else that's in my report? I completely agree, Jane. You're right in your comment in chat. If not, then let's move on then to item 3.1, which is no, it's not. I'm getting ahead of myself. I tell you. Yes, I am getting hopelessly ahead of myself. Sorry, I've ticked off too many things on my agenda. I should go next to the draft minutes of the Council of Governors meeting from the 3rd of February, which are there for information. If anybody's got any questions or comments, please shout. If not, then we will move on. Jane, just in time.
Sorry for my lateness. Jane
No,
Marshall.
that's all right, Jane, don't worry.
Jane Marshall, Director of Strategy. I was present at this meeting, Chair, but I'm not on the attendance list, so could that
Of course.
that point be addressed? Thank you.
Of course. Sorry about that.
It's all right.
Let's move on then to the Chief Executive's report. Sarah.
Thank you, Kevin. So, morning everyone. I'm Sarah Connery. I'm Chief Executive here at Lincolnshire Partnership NHS Foundation Trust. So I'm just going to run through some high-level pieces from the last since the last board at national, regional, and local level. So, first of all, we always start with a bit of an update around COVID-19. So we've had our Living with COVID-19 guidance, and it's been followed with some more detailed guidance from NHSEI as well around our approach going forward to infection prevention and control. So just to try and summarise, our staff will still be required to do testing on a regular basis and upload those results onto the government website, and continue to isolate as well following a positive test. We're just working through, we've been working around the guidance in terms of what that means for our bed capacity, in terms of social distancing as well, but we're really keen to make sure that with us moving back to sort of pre-pandemic requirements, that we maintain a manageable bed capacity to make sure that our ward environments are therapeutic, in line with Royal College of Psychiatry guidance. We are still asking people whenever they're in a clinical area to continue to wear a face mask. There is a slight nuance in terms of non-clinical areas, and we're asking building managers to work through that to make sure that we're keeping our patients and our staff safe. We're grateful for how staff continue to follow infection prevention control measures, and the approach we're taking is just to ask, as we move into sort of areas of grey and personal choice in some areas, that people remain respectful of that personal choice, because we all have different levels of comfort in terms of the approach to mask wearing, for example. So just want to make sure that we keep the conversations going where people are feeling uncomfortable how things are going. In terms of national and regional, there is a later paper about ambulance handovers. Urgent and emergency care has been particularly pressured, particularly over the Easter bank holiday weekend, and we had a bit of a learning lessons event last night across the system in terms of how can we plan together better, respond together better, as we have more bank holiday weekends coming up. So that was a really positive event to sort of talk about where we got things right, but also how we can improve our responses for the future. Cost of living pressures. So we're aware with the rising cost of living, particularly the price of fuel, that many staff are struggling with increasing costs. We've been talking as an executive team, a senior leadership team across the system as well, about how we can not only use our lobbying powers to make sure that staff are getting a fair deal, but what can we do locally as well to make sure that people are being reimbursed for additional costs. So we have agreed across the system a bit of a local short-term uplift for business mile rates, and that's across the Lincolnshire system, and we'll keep that under regular review, and we do benchmark across other trusts in the East Midlands and the region, and indeed nationally as well. Just wanted to flag that there is a call for evidence from the government about a upcoming mental health and wellbeing 10-year strategy. This 10-year plan will build on the ambitions of the long-term plan and look at the wider determinants of mental health and wellbeing. So I'd urge people to have a look at that and input their comments. It runs until the 5th of July this year, so lots of opportunity and time to be able to share your views on that. In terms of Lincolnshire, so we continue to press ahead with our Lincolnshire Health and Care Collaborative. Last night we agreed our system plan submission in terms of the financial position and what we're aiming for in terms of our performance targets for 22-23. As we've discussed as a board, we now need to make sure that we're investing our energies in talking as a system about how we get to sustainable financial balance over the next few years, to make sure that we're using our resources as effectively as possible to provide the highest level of patient care. In terms of our Mental Health, Learning Disability and Autism Alliance, we're really pushing forward in terms of our priorities and outcomes. We've had various workshop sessions with a number of our partners, particularly with local authority and the voluntary sector as well, about how we're going to push forward and plough ahead. It's been confirmed that the Alliance will be all age, including children and young people and older adults, which is great in terms of making sure that we're connected in the right areas to make sure that we're getting our transitions right and making sure that there's equality of access across the whole age pathway. So we're looking at starting well, living well and aging well as three sort of like a framework to be able to drive our work forward. We also had an absolutely fantastic community mental health transformation event yesterday in Grantham. COVID safe, but lots of partners brought together, including the national NHSEI team as well, and the regional NHSEI team, to really talk about the work that we've done so far. There was lots of personal stories. It was quite a moving event. And then in the afternoon, talking about how we're going to improve what we're offering at a primary care network level. So more on that in later, but I just wanted to feedback it was such a positive event. In terms of further working with our system, we're offering all of our substantive staff a wellbeing day. It's so important that our staff get time to recharge their batteries and take proper leave. So in recognition of the huge efforts that staff have shown over 21-22, we've agreed that we'll be allowing an additional wellbeing event. So that's something really positive. In addition to that, we've got our NHS Lincolnshire Staff Recognition Programme. So this is a really exciting programme where we're asking staff to choose a sapling of their choice, and then they can either collect the sapling to plant in their area of their choice, or it's going into an NHS woodland within Lincolnshire. So really demonstrates our commitment to the green agenda. And there's a really great website where people can put their choices in and people can share their COVID stories. Again, really moving to just sit and take some time to read some of those personal COVID journeys, and something really affirmative to do in terms of the future, in terms of that tree planting programme. This is Ananta's last board. I just want to say a personal thank you to Ananta for all that she's done for the trust and the system. Welcoming Dr. Jazz Full, who'll be joining our executive team and board in the interim. Jazz is a valued member of the senior leadership team already, and he'll do an absolutely outstanding job. And they're in the process of handing over now. And we have kicked off the recruitment for our new medical director, but just wanted time to say thank you to Ananta. We've also started again our divisional time to reflect, review and plan session. So over the past 2 months, we've had a session with specialist services and also older adults. And it's been absolutely brilliant to have that protected time just to review together with the senior leadership teams within those divisions, what's been achieved, how the teams are feeling, but importantly, what we need to do going forward to make sure that we're maximising opportunities and living our ambitions. In terms of celebrating success, massive well done to Jodie Gunson, who's been shortlisted for Nursing Associate Trainee of the Year. Jodie was nominated for being a brilliant advocate for the nursing associate role, which is such an important one, and frequently supporting career conversations with colleagues across the wider trust who might be thinking about taking that role. So best of luck for Jodie for the final award ceremony. So in terms of just a summary, I think the impact of COVID at the minute, it is continuing to have an effect in terms of our demand and capacity, but as always, just want to say a massive thank you to each and every one of our staff for all that they continue to do. We've got to maintain our vigilance around infection prevention and control, even as we move forward into our sort of business as usual going forward. But just want to say a massive thank you to our staff for all that they continue to do. So I'll stop there, Kevin, and I'm happy to receive any comments or take any questions. Thank you.
Thank you, Sarah. I'd just to add your thanks to what our staff continue to do every day, which is quite extraordinary. So questions or comments for Sarah? Tim.
Thanks, Chair. Thanks, Sarah, for the usual very comprehensive and helpful report. Just a quick question around the divisional time to reflect and the question that you've been asking around what the exec team or what the board of directors can do to help support them anymore. I wondered if there's anything you can give us sort of an early heads up. I recognise, you know, there's more conversations to be had, and I'm sure it will come back, but I'm just sort of curious around that. The other one, it was a quick question around the government mental health and wellbeing plan. Is there a timeline when that will be pulled together and published by government? Thank you.
Thank you. So in terms of my reflections, the two key themes, I think, from the divisional time to reflect, review and plan sessions have been the exec team and the board sort of holding the risk, you know, as we realise our ambition to support people to live well in their communities. Sometimes we're asking people to you know, engage in positive risk taking around patient care plans. So there's just something about us owning that and supporting the teams with that positive risk taking. So what, you know, one of the actions was to we've done it previously, but write that letter of support in terms of making sure that staff are feeling supported with that. And the second area is around advocacy and really pushing for that parity of esteem. And I mean that within our own organisation as well as in the system. So, you know, we had the older adults division, and I think the long-term plan has focused a lot on children and young people, but, you know, where's the focus on dementia? How do we ensure that there's equality of service provision across all ages? We don't have psychology specific provision within older adults, for example, but we have it for adults. So, you know, how do we work through that disparity? And in terms of the 10-year strategy, the plan at the minute is before the end of the calendar year. So make of that what you will. Thank you.
Thanks, Tim. Di.
Thanks, Sarah, for a very comprehensive report. You talk in the report about the appointments to the ICB board, and I noted in Kevin's report actually the real need, you know, for us to be bold and think differently about how we work as a system. And so my question really is, I know you can't say anything about detail, but whether you could perhaps say something perhaps more overarching about what attempts have been made to ensure that we're going to have real diversity at that ICB board level, because that will be in part, I think, how we move forward with that bold agenda.
Yeah, thank you. As you say, I was desperate to put names down in the paper. We're told very in no uncertain terms, no, you're not allowed to do that. So I think it's a really good challenge, and I know that there's been a lot of external support in those appointments to make sure that we've got a good mix in terms of the representation within those appointments. The statutory roles are the ones that have been appointed to thus far, and I think at every point when we're going forward in terms of when we have got turnover and vacancies, that we are actually connecting on a weekly basis between our system partners to make sure we're saying, is this an opportunity to do things differently? So not in any structured way, but just as a way to start to be able to think about the future. But it is really difficult while we're still working under the I don't want to say the old regime, because that makes it sound very sort of structured and stable, but you know, we still haven't got that legislated support in terms of the 1st of July. So it's trying to work within the current regime, but have one eye to how it's going to work in the future while these appointments go on. But definitely the diversity has been a thread through that recruitment process. I hope that answers your question. Thank you.
Thanks, Di. Thank you, Sarah. Any other questions for Sarah? Don't see any. Sarah, thank you very much for characteristically comprehensive and helpful report. Grateful.
Thank you.
Right, despite my attempt earlier to move on to item 3.1 prematurely, let's have another go and move on to item 3.1. Anita.
Hello, I'm Anita Lewin. I'm the Director of Nursing, AHPs and Quality here at LPFT. Just presenting to the board that the public risk register, as always, just to note, there are 32 risks in addition that are monitored at divisional and corporate level. So these are the 17 risks that we see here and at our private board, but there are many more additional risks that are monitored within the divisions and don't kind of reach the thresholds to be reported to board. Just in terms of updates since the last time, so the current risk score for 180 and 180 relates to sorry, I'm just got the wrong bit of paper in front of me. So 180 relates to CAMS and some of the capacity issues, which is some of the work that we spoke about earlier. But I also wanted to just, from my point of view, before I pass on to colleagues, in terms of the Philip training, this was something that was raised at the last board about whether we needed to extend the target risk date, given the impact that Omicron had on our planned target rates. We have extended that target risk level, but I did want to bring to the board's attention that whilst the overall compliance is just under 60%, our inpatient wards, that's the overall compliance level for the organisation, but our inpatient wards, both in older adults and the adult inpatients, are now just both shy of 65%. So the improvement work is really beginning to have an impact. And special thanks to everybody. We've heard throughout the morning about kind of the impacts and kind of staffing and capacity, etc. And to kind of get that training back up and running is no mean feat. So special thanks to people. But I'm happy to pass over to other executive colleagues if there's any updates on any of those risks that they're the executive lead for, or otherwise I'm happy to take any questions.
Thank you, Anita. Jane, you've got a comment on risk 18, and then I'll come to colleagues that want to ask questions. Jane.
Thank you, Chair. Jane Marshall, Director of Strategy. A comment on risk 18, which relates to the risk around the levels of staffing on our inpatient wards. That has a score, a current risk level score of 12, which is high. But the board assurance framework that we'll consider later in the meeting indicates a higher score than that. It's a timing issue. So in terms of when the reports were published, so that will be updated in future risk registers to reflect properly the BAF score.
Thanks, Jane. That's a helpful bit of clarification. I think we're probably all focused on the substance of what we're doing, as much as how we grade the precise level of risk. But it's as well to have for the record an understanding of why they might be slightly different. Chris, I'm going to let you comment first, and then I'll come on to colleagues with questions. Chris.
Thank you, Chair. Yeah, Chris Higgins, Director of Operations. It was just to flag there's a similar question or comment in terms of risk 178 and the consistency with the BAF, which Peter's probably going to pick up under the BAF section, but we've got a plan around that. Excuse me. And then just to say that it's been picked up through other committees, through the Sustainability Committee, around current risk around children and young people's access to inpatient beds. And there's a consequence of that there is times when young people have been having to be admitted to environments we wouldn't always want to admit them to, such as adult environments at times. So there is a risk being flagged, and we are going to add that to the risk register shortly.
Will that be on the risk register for the next board, Chris?
It will, yeah, definitely.
Okay, thank you. Okay, questions. Sharon, I think I've got you first.
Thank you, Chair. Sharon Robson, Non-Executive Director. Thank you, Anita. I just wanted to throw in a bit of challenge around risk 178, which relates to autism diagnosis. And I'd like to challenge the controls in place around that risk, because I don't think it properly reflects the rigour and leadership that LPFT have demonstrated around the Lincolnshire All Age Autism Strategy, which is one of our biggest controls around this area. And that strategy did identify that demand had increased and there was a requirement to review diagnostics in 2019. So I just wanted your opinion on whether that control should be strengthened. And in terms of the progress to date, given the importance, I'd like some assurance that the model in place, in your opinion, will address the strategic intention outlined in that strategy, and also some timescales around that. Thank you.
Thanks, Sharon.
I noticed both Chris and Sarah have both
Did
switched
I?
their cameras on for this, so I am actually going to bow out of this and hand over to the two executive, the executive and chief executive that are leading this work.
Thanks, Nita. Who wants to go first? Sarah.
Shall I go first and then yeah, so I think we've got I think it's a really good challenge, Sharon. I think we've put in that additional capacity to meet the demand, but tied into all of that is the flow between children and young people's and adults diagnosis, and we still have the gap. So there is a plan. I can't speak in detail about it because we're in public, but there is a procurement plan in terms of making sure that the bridge is gapped within this financial year. As an additional control, we have now got our autism programme lead for the system. She started on the 1st of April. Unfortunately, because of one reason or another, has not been able to start in that role because of illness. So we will get there, and that dedicated leadership capacity is part of what will need to be going into those controls. So I think we are missing something there. So I hope that gives some assurance. It's just not necessarily reflected in those controls, which do need updating. But I didn't know whether Chris wanted to update specifically on the demand and capacity around adult diagnosis.
Thank you, Sarah. Chris, before you do, just to clarify for members of the public, the reason that you can't discuss that procurement in public is because it is commercially sensitive. It's not any sort of other secret squirrelness going on. It's because there are commercial sensitivities which preclude it being discussed in public right now. Correct? Thank you. Chris.
Yeah, no, absolutely great challenge there in terms of this is that from a purely waiting time perspective, which is kind of what instigated this specific risk, is we've had a funding agreed to be able to increase capacity of the service, so that is in place, and we are currently finalising the trajectory with the team about what's reasonable in terms of expected recruitment, working with alternative providers to set a progressive trajectory for when performance will be back on track. Absolutely take the point that the controls are not quite as strong as they should be, and I will make sure we review that for next time and that we strengthen them.
Thank you both.
Thanks, Chris, and thank you, Sharon. I mean, really good challenge there, and helpful responses. Thank you. Tim.
Thanks, Chair. Tim Harry, Non-Exec Director. My question is really around risk number 155 and demand, but obviously it plays into some of the other risks as well. And my apologies if I've missed this elsewhere. I just wondered what work has been done both locally and potentially nationally around predictive work around where the level of demand is actually going, because I note in the risk that the demand is still increasing, but do we know where's it going to be in 3, 6, 9, sort of 12 months?
Again, I'm going to pass to Chris. I see in the risk that we are due to give an update in June 22 around that one. But Chris, I know you're doing lots of work within the operational divisions, so I'll leave it with you to update and answer the question.
Thanks, Anita. Chris.
Yeah, thank you. Yeah, again, good question on that. I think it's really difficult to tell. I think is probably the what I would say in terms of where demand is going to go. Nationally, it's not clear, and it's different for different services. So if we look at children and young people's services, which the board's quite well cited on, is that demand for those services came late. They came, we coped quite well during the pandemic, but it's at these latter stages where demand has suddenly increased, and it's difficult to predict where it's going. What we are doing in the services is looking at kind of modelling that through, making some assumptions on what we think may or may not happen with demand, and trying to scenario plan on that basis. And there is a paper for children and young people's service specifically coming to Sustainability Committee next month that sets some of that out. There'll be an opportunity for non-executive directors to challenge and confirm some of the assumptions in there, but it is really difficult. All I would say though at the same time is that as part of the long-term plan, there's an ambition to increase access and expand services out anyway, and so as we work with our local commissioners to increase the access and the scale of services, we should be able to meet some of that demand in future years. But at the moment, I think it's a bit of a crystal ball in terms of where it's going to land.
Yeah, thanks, Chris. And I fully support what you're saying about, the scenario planning. That's the best you can do in such a complex and not easy to predict. Thank you.
Thanks, Tim. Chris, before you disappear, bring yourself back on camera. The challenge then is how we work that scenario planning into our forward-looking resource and finance plans, and it would just be helpful to have a couple of words on how robust we think our kind of strategic plans are to changes in demand scenarios.
Yeah, agreed. No, absolutely. I will. I think in terms of there's a paper and a second paper coming to Sustainability Committee next month that sets out the range of new access targets that have been set in the long-term plan, and where we think we are in terms of meeting them currently with current resources, and what do we think we need to do to meet them. And within that report, it will demonstrate there are some gaps in terms of current demand versus resources and expected access rates in terms of resources, and there's some questions for us as an organisation about how do we prioritise, well, as a system, how do we prioritise investment in those areas or not. And this current planning round, we've focused quite rightly on patient safety issues. So and that's reflected in the you'll see an integrated performance report later, is that we've prioritised investment in those areas where there's patient safety issues, children waiting now, for example, over just broadening access generally. But there are some choices to be made with the resources we've got available. So in terms of the question, it's difficult to reliably predict what's coming next. We've got some measures in terms of access that we know we need to meet, and we've got current demand and some scenario planning, but that's probably as good as it gets at the moment.
And I'm sure you're right, Chris, that we are, as an organisation, going to be facing some difficult choices. We need to try to do what we can to make sure that we have a Lincolnshire system that facilitates the right answers to some of those difficult choices. Jane.
Thank you, Chair. Jane Marshall, Director of Strategy. To support the work, we know through this year's planning round that we've got an increased level of sophistication in our modelling ability to tie together activity, patient access to services, workforce and finances. So that will help us do that trajectory modelling and the resource implications of doing the work, seeing those patients.
Thanks, Jane. That's really helpful. Okay, colleagues are happy. Let's move on then. Thank you for introducing the risk register, Anita. We'll move on to item 4.1, which is the report from the Quality Committee meeting on the 14th of April. Sharon, are you speaking to that? Yes.
Yes, thank you, Chair. So this report is the highlights and minutes of the Quality Committee, which was held on the 28th of April, I believe. And the report reflects the phenomenal.
I think it was the 14th. The 28th is today.
Oh, sorry, beg your pardon. 14th of April. Time flies. The report reflects the phenomenal amount of work in progress to both sustain and improve quality of care and patient experiences of care. I'd just like to highlight two areas to the board. The first is in relation to infection control, and despite the governance arrangements in place, an internal audit report has identified that some challenges in relation to infection prevention and control in some areas within the trust, and a robust plan has been put in place to address this. The second area to bring to your attention is that as processes for defining, assuring and improving quality are constantly evolving, the Quality Committee is undertaking a review of the committees that report to Quality Committee to ensure appropriate information is escalated, analysed and challenged by the Quality Committee. So those are the two areas I wanted to raise, and are there any questions?
Excuse me, thank you, Sharon. Any questions or comments for Sharon? I'll give people a couple of seconds to indicate. Andy.
Thank you, Chair. Andy Spring, non-exec director. Sharon, I just wondered if you could comment in terms of the quality committees. I believe it's where we're monitoring the rollout of electronic prescribing. Just whether you could comment on how that is going, or whether one of the executives could comment on how that's going, and whether it's had any material impact in terms of medicines errors and incidents.
Thank you. It does report, Andy, to the Quality Committee, and the Quality Committee reviewed that review on a regular basis. I think, you know, it's fair to say that a lot of work has gone into the rollout. It's been a fairly slow process over the last 12 months. I'm going to defer to Ananta around the question of whether we're actually seeing any reduction in incidents related to medicines, etc.
Yeah, thanks, Sharon. Happy to take that question. I'm Ananta Dave, Medical Director. So the EPMA project has helped us to roll out the process to the rehabilitation older adults and some of the inpatient wards. So in terms of progress, what we've been able to do is get onto the latest version of the software, which allows us to integrate EPMA and RIO, which is our electronic patient system. So we've now got a provider in place who will help us integrate both those systems. The software has been updated, so that's good progress. In terms of what impact it has had so far, we will be presenting a further paper to Quality Committee. It has certainly led to more accurate prescription writing and a reduction in errors. The errors that are reported are the ones which are picked up by EPMA very quickly, so they are not serious errors, but they are errors in some minor prescribing and the writing down, but which is a good way of picking up errors very quickly and ensuring that systems are in place. So feedback from the trainees and from the doctors and the ward staff who use it is that it's quick and easy to adapt to, saves time and improves accuracy of prescribing. Thank you.
Thanks, Ananta. Anita, I think you have a comment as well.
I have just on that, and I am conscious this has been, a focus and has been raised several times by the board, and I think it's a fair challenge, Andy, that you give us. I have put a small paragraph within the integrated performance report this time around the medication errors, but have also asked going forward that the Deputy Director of Nursing and the Chief Pharmacist do an ongoing paragraph within the quality section of the integrated performance report, covering off the actions taken and the learning from some of the incidents that do continue to happen. So it doesn't get lost, and that information doesn't get lost as our IPR develops.
And I think I note the comment in the chat, EPMA stands for Electronic Prescribing and Medicines Administration. Sorry, we tend to use acronyms. Sorry about it.
No, that's quite all right, Ananta. Excellent. Thank you very much. Good question, Andy, and good responses. Note your comment in chat. I agree with you. That's exactly the level of assurance that I think you were after, and it works for me as well. So thank you. Any other questions or comments for Sharon before we move on? No. So we'll move on then to item 4.2, which I think is you, Ananta, and the annual safeguarding declaration.
So you'll be presenting, Anita, the safeguarding report.
Yes, I've got the annual safeguarding report. So the Trust Board are required to publish an annual declaration of compliance with safeguarding and certain activity around safeguarding. This has been to the Quality Committee with a couple of minor amendments requested, which have been changed. The declaration is here. I think just one thing I wanted to add, and it was a conversation that we did have at Quality Committee last week, that there's been lots of changes within LPFT in the safeguarding arena, both within the team, the way we report, legislative committee and how that operates. It was commented by the chair of the Quality Committee and other non-executive directors that the level of assurance around our safeguarding activity that now is reported into the Quality Committee feels more robust than it has done for some time. We've had lots of changes, lots of developments, all that are very positive. CCG colleagues are always at our legislative committee and are always very positive about our approach to safeguarding within LPFT. So despite all the changes over the last 2 years, we continue to provide robust assurance around the implementation of safeguarding within LPFT. And I'm happy to leave it there, and I'm happy to take any comments and questions.
Thank you, Anita. Are there any comments or questions for Anita? If not, and bearing in mind this is been seen by Quality Committee, as a board, though, we need to approve the publication of the statement. So grateful if colleagues could indicate in chat that they are content to approve publication of the statement as presented. Excellent. That's a yes. Thank you very much, Anita. I think the next item is yours. So would you mind keeping the mic, as it were, and we'll do 4.2 and then perhaps have a break after this next item.
Certainly. So this is, so as a board and as an organisation, we are required twice a year to undertake what we've known as a safe staffing review, but I think it's really clear that we make the demarcation. This is around staffing establishments on our inpatient facilities. I know we have been, and I will cover it probably as part of this and some of it as part of the IPR. This isn't about some of the issues we heard as a board last time about some of the shortness of staff and some of the impact of short-term sickness and long-term sickness and vacancies. This is around the staffing establishments of our inpatient facilities. Many of us, we are very lucky to have in the organisation Kerry Woodcock, who is one of kind of the leading people in the country really around her knowledge on the M-Host tool and everything that goes into it. So she does try very hard to educate us all on how we come to the establishments, and many of the NEDs that are on this call had the opportunity to kind of have a training session from Kerry, but they are available at any time. So this report really goes through, so Kerry works very hard with the two divisions that have inpatient facilities. They undertake a very detailed analysis of the level of acuity of the patients on the wards. They look at the current staffing establishments. There's lots of kind of triangulation of data around professional judgment that's brought into this. I think one of the things that I did want to identify, and my colleague Jane Marshall spoke about it earlier, but around the workforce plans and the considerable amount of work that has taken place really in the last 12 months around some of the new roles, how we've increased our kind of commitment to apprentice nurses, our commitment to the nursing associate role, our commitment to advanced clinical practice. But what we've been because on paper those numbers look as if they've increased hugely on what we've got coming through, but unfortunately the advanced piece of work that Amy Beaton and the People Committee have been looking at in terms of pipeline, whilst we can see that we've done a huge increase, the increase is still not enough to meet kind of the retirement plans of staff and kind of some of the what we know is our turnover. So whilst there's lots been done to increase kind of the pool that we can take from, that there certainly is much more to do. And I am absolutely thrilled, and it is a small line in here, but it would be remiss of me if I didn't thank Lincoln University for putting on a learning disability nursing course this year. We have been waiting for this for a long time, and that will make an impact to LPFT. So special thanks that we finally managed to get that done. So the paper goes on to explain how we do the review process. We look at the safeguards and mitigations, and then we look at the recommended changes to staffing establishments that each of the wards ask for. I won't go into the detail of each ward and the establishments. The two main areas really so Ash Villa was obviously opened to us in March 21, so a year has just gone over a year really, and this was their first detailed staffing establishment. And what was clear was we hadn't staffed it to the original kind of plan, so there is a business case that's going together now just to increase the staffing of that unit. It was a unit that we agreed to put additional staffing in to support the location and the client group. And Charlesworth Ward was excluded from the original plan because it is having a very detailed quality improvement project that the Director of Operations, Chris Higgins, has commissioned. And as part of that project, there is an incredibly detailed piece of work that's going on around staffing and activity on those wards, which it goes further than the work we do with this, that will potentially give us some additional information. Just in terms of recommendations from this paper, but just in terms of one other further piece of information, between now and October, November, when we undertake this again, we are doing a really detailed piece of work around the skill mix on our inpatient wards, around our qualified professionals versus kind of healthcare support workers. And I'm keen that we include the role of the nursing associate in that. We've had in the organisation very productive meetings about the role of the nursing associate and how we can kind of include those in all of our inpatient facilities. And I believe People Committee are going to be receiving a proposal around that, but really looking at our staffing ratios, benchmarking ourselves against other organisations. So very much the focus of this report that comes later in the year will be around the skill mix as opposed to just numbers in establishments. But going forward, in terms of the recommendations that are required, the older adults are not recommending any changes to their current establishment. We know we have Manthorpe Ward that is temporarily closed while they're doing some work around there. Hopefully some of the changes in COVID management of patients on admission, etc., will allow us to press forward with opening up Manthorpe Ward 2. But the adult inpatient and urgent care division are also not recommending any changes other than one I've spoken about regarding Ash Villa. And there will be a detailed separate paper that is kind of goes through our business case processes around Charlesworth Ward. So it is a staffing establishment paper as opposed to a safe staffing paper. In terms of safe staffing, I will be covering off some of the work that we are doing around that when it is the IPR section. It's imperative that we start to focus on some of this feedback we're getting from staff when they talk about kind of the firefighting shifts and how difficult it is. But this isn't the process that does this. This is about the establishments, and on the whole, the staff and the managers report in terms of their actual establishments that they are happy with the way that they are. So I'm happy to take questions. It is a detailed paper, but I hope I've managed to pick out the pertinent points.
So Anita, just to be clear, what is the specific ask of the board? Are we just being asked to note this for now?
Yes, and to be assured that the staffing establishment process happens twice a year in line with the national requirements, and that we do it thoroughly and following a very detailed process, and it is a very thorough process.
The thing that's of most interest to me is to see how this process feeds into the wider review of workforce requirements that I know that Chris is undertaking, but that's not a discussion for now.
Yeah.
But to see, I'm really interested to see how that plays out as part of that process and how we triangulate all of that. But there'll be product from that work that comes to the board at the right moment. So I'm not seeking to preempt that.
No, absolutely, and that's part of the skill mix work that we're talking
Yes.
about as well, and the new roles and all the work that Chris and Amy, kind of myself, Jane, the whole team are kind of linking very closely and to bring all that together. Absolutely.
And there's a bit of reflection that we need, again, not necessarily right now, and it's a conversation that I'm quite happy to have offline, but there is a bit of consideration that we need to give to how we bring all of those strands together and how we report them to board alongside our ongoing kind of financial plan, so that we can make sense of the work that's been done and draw some conclusions from it, because there are a lot of moving parts there, and we need to be able to present them to board in a way that is intelligible and useful. But that's a discussion for that we don't necessarily have to have right now. I'll move on to colleagues who've got questions and comments. Tim.
Thanks, Kevin. So Tim Harry, non-exec director. Thanks, Anita. Really good paper. Really enjoyed reading it. And as you inferred, having had the most training was very helpful in sort of understanding. I've got a bit of a technical question. In Appendix 1, there are numbers there against each ward and differentials between professional judgment and most estimate. My question is really, does that relate to the note at the bottom in terms of what most define, and or is this around the question of understanding the difference between optimal versus safe reconciliation? Because I know we had that sort of discussion to try and understand the difference.
A little bit of both, which is very helpful. So it's a little bit of both. So in terms of the professional judgment, for example, so some of the technical stuff is done by the number of patients, the number of beds, the level of acuity, and you have to record the acuity of each patient at kind of 3 times a day, etc. Now, obviously during COVID, especially during our outbreaks, we reduced admissions onto wards. So some of the wards were running at, reduced capacity, etc. So the M-host kind of was going, oh, this is marvellous. You've only now got 9 beds on this ward. You can reduce your staffing by kind of 9 staff, and it was like, no, we really can't. And so it is, and that is such the importance of the professional judgment. And to be fair, I've seen it both ways. I've seen when the M-host is kind of recommending that, we increase our staffing considerably, and the staff have kind of said, and they've been really good and said, actually, no, those 2 weeks were really an unprecedented time in terms of demand. We would need to see it prolonged. Our staff are really into the process now and really engaged, and I thank Kerry Woolcott for that. She's really helped us all over the years learn how to do this properly. I know Kerry is going around lots of organisations now and supporting them to get kind of the process that we have in LPFT kind of firmly embedded the way that we have managed to do.
Thanks, Eve. That's very reassuring. Thank you.
Thanks, Tim. I've got Di.
Thanks, Anita. As you know, this is an area that I'm really interested in, and I was really pleased to see the paper, and I took good assurance from this. I think it gives us a much stronger foundation on which to build, and also in terms of the related work that is going on around this. So absolutely commend the paper. I've got a couple of questions, if I may. The first one is that we talk in the paper about the conversion of Band 5 roles to Band 6 in particular in terms of supporting leadership capacity. And I guess my question there is, are they vacant posts that we've got, and so effectively we are, we're increasing the leadership capacity and recruiting to that going forward? Or is it that we've got folk in those posts who we're asking to step up in terms of the leadership? And I appreciate it may be a combination of both. And so I just wanted to get a sense of, are we supporting that shift with training and development for those individuals where that is happening?
So, and I notice Chris has asked to comment, but I'll start first. I'll take writer's prerogative and then hand over to Chris. I think this came from 2 points really, Diane. We had a long discussion, and actually there was a report out this week about mental health nursing and just a huge kind of exodus of people from inpatient facilities into community settings, where often the banding of staff in community settings is higher than that of people in the acute wards. It's been something that all organisations have struggled with for a long time, that there are highest acuity of patients and kind of potentially our lowest band of staff. So some of it was around a retention programme and to try and make the staff in those areas see a career pathway within those areas without having to kind of leave there to go. And so, especially as staff were getting more experienced, we didn't want them to think that they had to leave kind of the inpatient areas to get their band 6, their band 7, and to keep that skills and knowledge in the area that we wanted. In terms of the leadership development and training and what comes with that, you heard Chris Higgins earlier speak about the work that we're looking to put in. Sorry, Chris, we're looking at the work that we need to put in for the staff. We've done some on the ground support and development and training, but it needs to be more than that. So I'm certainly working closely with my nursing directorate team, so my head of professional development, deputy director of nursing, to look at the additional support that we need to put in. There was a very sobering report that came out this week about mental health nursing, and we really need to grasp that as an organisation. And I'm really very focused on what we need to do, certainly over the next 6 to 12 months, to really address some of the nursing issues that have been identified. But it's not just about nursing, but that some of the we need nurses in our acute inpatient facilities. There are some things that only nurses can do, and it's imperative that we absolutely make the most of that workforce and they feel valued, and we keep them within LPFT.
Thanks for that, Anita. Just one more question, if I may, and apologies if this kind of picks up some of the comments in the chat. I'm just not sure that I've got an answer really, if indeed there is one. So one of the things I was interested in the paper was particularly about the rehabilitation services, as having particularly high levels of occupancy, and that made me think about the sort of the patient flow through our services and how we are seeing this. And I appreciate it's a safer staffing paper, but how we see this within the context of that dynamic in terms of, and what in the light of that changing acuity are we thinking about for people who are going through the service in terms of how long they stay at different points, and can we support them better to move on? So I think the workforce side of things is one side of things. I think the patient flow side of things is the other side of things. And so I guess I just wanted some assurance that we are, at some point, we will join that all up together and it will help us.
I can comment, but I won't. I stole Chris's thunder last time. It'd be rude of me to do it again. Yeah, so I'll let Chris answer that one.
Thanks, Anita. So, Chris.
Yeah, just have to stand. You might want to add to this, Anita. Just, but in terms, it's worth differentiating between the occupancy levels on our rehab units versus occupancy levels on the acute wards, and certainly on acute ward. Therapeutic levels, you would hope to aim somewhere around 85%, although that I don't think many places in the country operate that way, but that's the ideal in terms of kind of national best practice. from the rehab wards, we do tend to occupy a maximum occupancy just because people are within such a long time, and we plan around that. But in terms of that acuity, there's much more control over acuity, I would say, in the rehab wards, because we can plan admissions and we can think about that in advance. Where obviously the acute wards is very different. It's here and now, and you take who comes through the door and support them as best you can. So so there is a bit of there's a nuance there that I would say is slightly different for rehab.
Thanks. Thank you. Thanks, Chris. Thank you, Di. Anita, thank you for presenting that paper, which the board notes. I think that's been a really helpful, it's triggered a really helpful discussion and just illustrated for me how much we have to triangulate some of these strands of activity, and how we need to think collectively about how best we do that, because I'm not sure at the moment we structure our board discussions in a way that enables us properly and effectively to see those links. But
absolutely, I do think the next piece of work around skill mix is going to be really critical to feed into the work that Chris has already spoken about, and we've heard kind of from Jane earlier. That skill mix is really going to be the next big piece of work for us.
Absolutely. Thank you, Anita. I'm going to suggest we take a short break now. It is currently, by my clock, 10:40. So can we reconvene at 10:50, please? 10 minutes time. Thank you. Right, colleagues, are we happy to restart? It's 10:50. I'm not sure whether we've got everybody. It's always impossible to tell on Teams whether everyone is there or not. It's not like looking out over a room and you can see an empty chair. But I'm going to start anyway because I said 10:50 and it is 10:50. So let's move on then to item 4.4 on the agenda, which is Suicide Prevention Strategy Priorities 2022-23. Ananta, I think the item is yours.
Yes, thank you, Chair. Ananta Dave here, Medical Director at LPFT, and this paper is for information. This is an update on the suicide prevention strategy, which runs from 2020 to 2023. And I'll take the paper as read. And this update provides some details about the work that's been going on in the trust in terms of getting some more nuanced data through the thematic reviews, for example, so that we are able to get a better understanding of some of the common features or some of the groups which might be more affected by suicide for those people who have been open to our trust. There is also ongoing work, collaboration at system and national level to collect the data appropriately, to find out, areas of good practice from others, and to bring that learning back to our trust. So there is a lot of work going on in terms of collecting data, learning from our suicide serious investigations, where we have a learning from incidents group, contribute to the mortality surveillance committee and the assurance to the trust, and also in terms of our own training within the trust. We have a clear training program, and because we've been able to resume some face-to-face training over the last few weeks, the phase 3, the level 3 of training, which required face-to-face for optimal utilization of that safe space, has also now started making progress. So it gives some highlights about the work that's going on in the trust around suicide prevention, intervention, and postvention. Happy to take any questions. I do apologize, there are acronyms in the paper, which I always think I've got through them and I find some more, but happy to take any questions or provide any clarifications.
Thank you, Ananta. I'm always conscious that we operate in an acronym-rich environment, and I always have to apologise to people outside of the NHS for some of that. It's so easy to slip into, so please don't worry about that. It's an excellent report, really comprehensive, and provides the board, I think, with a really good level of assurance around the activity that we're engaged in. We're asked to, I think, note the content before I ask. Before I do so, as it were, on behalf of the board, I ask if colleagues have got any questions or comments. I don't see any. Ananta, thank you very much. I think the next item is yours as well, isn't it? Which is the learning from deaths report.
Yes, that's right. And again, this paper is for information, and it provides an overview of the work that's been ongoing in the trust around our monitoring, investigation, reporting, and governance arrangements around deaths. So it gives information about the various kinds of deaths that we look at and capture, the processes involved in various kinds of deaths, some patterns of the numbers of deaths over the years, with a narrative around the trends in older people and frailty deaths, which are the vast majority of the deaths that we have, and in many cases are due to expected causes. And it also gives an overview of the governance arrangements and how this is reported, and the work that's ongoing. Again, some overlap with suicide prevention, the work around the learning from incidents group, and the work that goes on regarding thematic review of suicides at the mortality surveillance committee, and the collaboration that we have through our learning from deaths lead at local, regional, and national level. Just something to keep an eye on is the ongoing work around the medical examiner pilot. So the role of medical examiners in acute trust is well established. We are in the process of understanding a bit more about how the medical examiner system can contribute to our understanding of deaths within mental health trusts, and we are a pilot, so there'll be more information about that going forward, but very happy to take any questions or provide any clarification. Thank you.
Thank you, Ananta. Again, a characteristically comprehensive and helpful report. Do colleagues have any questions or comments? Di's asked a comment in chat. Do you want to, rather than me read out your comment, Di, do you want to, but although it relates to the previous paper?
Well, okay, so so yes, that was just in terms of the suicide prevention strategy paper, and just in terms of that survey with staff working with bereaved families. I just wondered if there's a role for the Freedom to Speak Up Guardian, depending upon what's coming out of that. But you know, happy to talk some more about that beyond this meeting. I guess in terms of the learning from deaths paper, and it kind of links back to the suicide prevention strategy, it seems clear to me that we've got a number of indicators of risk, which are the same to a degree in both papers, I think. And I guess I just wondered, to what extent are we checking those against our current tools that we're using for risk assessment, planning and management, because it seems that there are some obvious signs that we could be heeding there, and it's what we do about that, I guess, in terms of prevention.
Yeah, thank you. Good question. So just to answer the first question, I think it's a good suggestion. So the survey results, where you know, we work very closely not only with the quality and safety team, but with our organizational development team. And in fact, we've set up some groups and processes in the trust to support staff where they're working with bereaved families or have been affected by patient suicide. I think there is a good level of reaching out to the Freedom to Speak Up Guardian if there are any you know, issues of that nature. But I think it's an interesting concept to explore whether there's more that we can do. And certainly I think as part of our conversations at Mortality Surveillance Committee, that's something that can be picked up. Regarding the risk indicators for suicide, you're right. So what we have tried to do is, for example, in the training program that we provide in the trust, we've tried to update it according to what's coming out of the thematic analysis. And so we do have things there which we didn't have explicitly before, whether it's the links to physical health, polypharmacy and prescribing, dual diagnosis or substance misuse. So those are present. And we've also tried to set up these groups, as I said, because sometimes the decisions around risk are not easy. I mean, risk prediction is not an accurate tool, and we all know that. So sometimes the decision making or the level of risk that people carry depends on the level of supervision support they get and whether they are provided with safe spaces when something goes wrong. So we are trying to do that as well as part of our training in order to bring staff together and have those reflective discussions. So that's the way it's being reflected in training. This is the start of our thematic evaluation or analysis. I mean, it has made a huge difference to have somebody in post full-time, Fiona Bone, as the suicide prevention and learning from a self-harm lead. So I think this is the beginning of work. As we go on, I think we'll see more detail and the linking back further from what's coming out of the themes into our training and our learning from that's work. Thank you.
That's great. Thank you. That's really helpful. Thanks, Chair.
No, thanks, Di. That is very helpful. Tim.
Hi, Nan. So just a point of clarification really around in the Learning from Deaths paper. On page 5, you make reference to a fact that we're going to be moving from the current framework to the patient safety framework, which is going to be more sort of system orientated. I just wondered if you could elaborate on what the implications are from that.
Yes. I mean, the patient safety framework is now coming up nationally, so we are in alignment with what is happening. But in terms of system working, I mean, as we come together closer as a system, we realize, for example, that many of the patients who are open to us, you know, receiving services from mental health services or in the past 6 months from our trust and whose deaths we review or investigate, were also, for example, open to other services. So they have, you know, what we call multimorbidity, a combination of physical and mental health problems. There are some, for example, you know, I was talking about dual diagnosis, and quite a few of our patients have problems with alcohol and substance misuse. So there is the need for joint learning and investigation with We Are With You, which is the substance misuse provider, or with primary care. So these things are again still in the very early stages where we are trying to work as a system in order to learn and, you know, have that joint learning and joint forums where we can discuss things. This is beginning to happen. The dual diagnosis Special interest group has been set up, for example, jointly between our trust and We Are With You, where one of the things we also do is to look at the learning coming out of some of these tragic deaths. So that's what we want to do at system level, and at the same time implement the National Patient Safety Framework.
Yeah, thanks. That makes perfect sense. Thank you very much.
Thank you, Tim. And I think lastly, a comment from Anita.
Thank you. And just so board members know that there has been commissioned down in Essex, actually, a large investigation into 1,500 deaths in Essex that's being led by Geraldine Strathdy. They have released some information on kind of the areas that should be covering as part of that investigation. So we did have a meeting early this week to look at our reporting, to look at how we kind of collate things to make. I'm quite certain it will be the mental health Ockenden, and there will be learning for us all. So I'm really keen that we look at all our reporting and the work that Ananta's already spoken about that goes through mortality surveillance and the learning from incidents, that actually we're covering off all the early findings that we kind of get drip feed through occasionally. So in terms of assurance for the board, we are starting to already look at those and look at aligning all of our meetings and all of our kind of committees to make sure that we cover everything off.
That's very helpful.
Thanks, Anita. That is very helpful. Thank you, Ananta.
That's my last paper for board, so because it's my last meeting, so just wanted to say thank you.
Is it? Well, that's a sad moment. I will miss the comprehensive nature of your reports, Ananta, and that's been a really helpful discussion. As ever, they spark interesting and useful discussions. So thank you.
Thank you.
Let's move on then, please, to item 5.1. Jane.
Thank you, Chair. And by contrast, I'm sorry, Jane Marshall here, Director of Strategy. By contrast, this is a very high level report, which shows us our first analysis of our position when we benchmark ourselves as an organisation on the NHS staff survey, the results of which the board considered at its March meeting when they were published. So this very positive report, I think, is a celebration of those areas where we benchmark really, really well, and those are itemised in the report against the 7 people promise indicators, which are part of the National People Strategy, and 2 additional questions on staff morale and staff engagement in organisational changes and contributing to the experience of work. And Lincolnshire Partnership has got a really good set of headline results when we compare ourselves both to our peer group, the 51 mental health learning disability trusts, when we compare ourselves to all NHS providers, the 217 NHS providers that there are, when we look regionally as well at our comparison. So a really great set of results for us, and part of our message to existing staff, but also staff who may be wanting to considering joining Lincolnshire Partnership, as an articulation of our ambition to be a model employer. And this is part of a continuous journey of improvement that we've been on, and the result of all of our work as we support our staff to have a great staff experience, the best we can make it. It is very positive, but there is still more work to do. So I wanted to give the board assurance that we've started the benchmarking process, that this report gives good assurance that we're comparing well, but we're not being complacent, and there are still areas that we need to address, and some of those are listed in this report, particularly to highlight for the board the ongoing challenge around workforce race equality standard and workforce disability equality standard, where there is still disparity in the experience of staff who are of a non-white heritage, or who may identify with a disability or long-term condition. So we are not being complacent, we're continuing to understand where we can learn from others on best practice, but also, Chair, we have been approached by NHS employers to share our good practice and learning as to why we've got the good results we have. So happy to take questions, but just to give the board assurance that further reports, as we get more benchmarking data available to us, will be coming through to the People Committee, the Trust People Committee, and then on to the Board of Directors. Thank you, Chair.
Thanks, Jane. Two quick observations. The first is that seeing these results in a context of the kind of challenges that the organisation has faced over the last year, both in terms of pressures from increased volumes of referrals, COVID, and our workforce issues, that puts it shines a particular light on it, doesn't it, and makes the results even more creditable. So that's my first observation, and it says a good deal about leadership and the culture in the organisation, which as a board we should be hugely appreciative of. The second observation is slightly more kind of nuanced, and that is that we know, don't we, that the headline figures mask some significant variations across bits of the organisation that we need to get a handle on and understand and respond to. That's an observation, not expecting you to come back on that, Jane, but it's just, in terms of the board's focus on all of this, that's something that we are aware of and need to continue to be focused on.
Thank you, Chair. And if I may make a quick comment.
Of course. To
give assurance that we have put in place a continuous staff engagement cycle, and the current there are two bits of that are ongoing at the moment. A specific conversation with staff, as you suggest, Chair, to get under the skin of some of the feedback that we've received as part of the NHS staff survey, which is called Walking in Your Shoes. That's ongoing at the moment. And then we have additional mini staff surveys, if you like, on a quarterly basis, and one of those has just been launched as well. So you're absolutely right, we will continue to get intelligence and continue to challenge ourselves about what staff are really thinking. And to note, we had a really good response rate to the staff survey. 63% of our staff responded, but 27% didn't. So how do we, and some of those 27% are our most pressurised 24-hour, 7 days a week services. So we do need absolutely to do what you suggest and be continuously vigilant. Thank you.
Thank you, Jane. Sarah.
Thank you. And just to thank you to Jane for the very balanced paper. I think is good, and so much to celebrate. And we had that conversation, didn't we, Jane, when we were about to open the email about our staff survey results, kind of holding our breath, given, as Kevin has said, such a challenged few years. But just in terms of, it's a good position on a benchmark basis as well, and there's so many elements to be celebrated. And I know the national team have been in touch about some people hoping to sort of learn from the trust as well. So I just wanted to say a thank you to the people team who have got us to that 64% response rate. They've gone on the wards with iPads to try and make sure that people had the time to be able to complete some of those really busy ward environments where people are struggling to even get a break. So I just wanted to say thank you for that dedication.
Thank you, Sarah. Andy.
Thanks, Chair. Andy Spring, non-exec director. I really just want to commend the executive team on obviously this report and what's happened. But it kind of, I've had the privilege of doing a few service visits with executive directors over the last few weeks. And this survey really has, to me, those visits have demonstrated that this survey is not untrue. It's true that they've had no issue in raising concerns that they may have, but they've been very positive and very feel very supported by the trust and by the organisation. Certainly the areas where I visited, it's not that they don't have issues, they actually we're very keen to flag issues they have, and also what they're doing to address them. So it just really supports that those executive, non-executive director visits do help support, you know, if you like, the survey results.
Thanks, Andy. I echo that from you know, visits that I've undertaken. You know, we know, don't we, that there are elements of our service where staff are working under significant pressure, and where at times it feels like that pressure is unrelenting, and you know, the difficulties that they face are you know, very hard to solve. But the results of the staff survey don't tell a lie, because overall the kind of response I get from staff when I visit services is, you know, is exactly consistent with what's in the results of the staff survey. So you know, absolutely echo the comments about you know, commending the leadership team for getting us to the position that this reports, and thank you, Jane, for presenting the summary this morning. It is still morning. Let's move on then, if colleagues are happy, to the integrated performance report. Mark, this is the time of the month that you look forward to more than any other, I know.
It is, Chair, it is. So good morning, everyone. Mark Platts, I'm the Director of Finance and Information for the Trust. So presenting today the integrated performance report. We continue to refine it. So I know we've been talking at a number of boards recently, board sessions, around how we can make the integrated report more integrated and kind of refine it and make the data in there more meaningful. So just a couple of quick highlights from the overall report for me today before I hand over to Chris. The long-term plan metrics that we discussed last month, we've now ensured that every metric where we're off track is referenced within the report. Now that's either within the operational update that Chris will talk through, or we do have a very detailed metrics tracking table towards the end of the report. So that will give updates on progress and planned kind of resolution on meeting those targets within the report. And Anita and the team have worked really hard to update the quality section. So there will be quite a few presenters of the report today, but I think it's important that we kind of give it the right airtime that we need to. So without further ado, if that's okay, Chris, can I hand over for you for the operational update? Thank you.
Okay, thanks, Mark. Yeah, Chris Higgins, Director of Operations. So just I'm reading from page 5 here, just for reference, but just to flag really the main headlines for March, where this data's taken from, is that it's just worth reminding ourselves that we're still in that month operating under the shadow of COVID and the implications that brings. And certainly in March, we were under quite considerable pressure with staff availability, and that still hasn't gone away completely, as we're all aware. That did lead to some temporary closures of wards to admissions because of COVID outbreaks and things that led subsequently to some people being placed out of area that we would call inappropriate out of area placements because of a lack of bed capacity in the local system. That peaked at about 5 in March, but we're down. By the time we write the report, we're down to 4 and we're down to 2 now. But just to say that risk hasn't gone away, in that we've got still added pressures, and that the beds, as we referenced earlier, in terms of occupancy level, are quite high at times, and there is a danger that people may have to go out of area if we have similar IPC restrictions and outbreaks. So we're just keeping a watching brief on that. But just for assurance to the board, is that something that's very close to my attention, and I keep daily oversight on that work and on the performance around it. And I chair an out of area reduction group for the system as SRO, just to keep oversight on what's happening in that area. So that work continues. It works just to flag that beyond COVID, we've talked about vacancies and vacancy rates on the other parts of the agenda. That is the biggest barrier to operational performance as we stand today. Service are operating relatively efficiently, using the best they can out of resources they've got, and funding flows seem to be coming to the right areas where we're getting pressures on services. We referenced autism weights and children's services earlier in the meeting. That workforce availability in the pipeline of workforce that we can expect to see over the coming months and years is the limiting factor about how quickly we can recover some of our waiting times. And so we're doing work with our HR colleagues and workforce experts to really try to predict what we think might happen, and that will then feed through to trajectory work on how quickly we think we'll recover on some of the areas where we're underperforming. Just to flag one particular service this month around the crisis enhanced home and treatment team for young people in the south. They're operating with a 50% vacancy rate, and that's impacting on their ability to provide that responsive service at that much needed crisis end of the service. Because of that, we've introduced some business continuity arrangements for a few months by diverting staff from other areas to prioritise that critical service. That's expected to last about 3 months. Will affect slightly on performance in terms of waiting times, but it's ensuring those most in need and most at risk are getting seen first. So we'll keep the board appraised of that. And then finally, just to pick up on comment at the end of my section really around, and again this was referenced earlier, around difficult choices that we need to make as a system around how we use our resources. There was a limited amount of investment available for this coming year that we've been negotiating with our local commissioners around how and where to spend that. We have chosen to spend that as a system in areas where there's patient safety issues, so prioritising CAM services, for example. But there are compounding factors there with targets around the long-term plan for increasing access to services, and it's this balance between we've already spread quite thinly with gaps across the service in terms of vacancies. If we grow farther quickly, we will compound that issue and we'll have more gaps in services, and there's a balance to be struck about how quickly you grow whilst needing to meet some of those targets. So at this moment we take a pragmatic view that will prioritise patient safety issues, and there's a paper coming to the Sustainability Committee next month that sets out some of those NHSEI access targets and where we think we are in relation to them, again for an opportunity to confirm and challenge the approach.
Thanks, Chris. And it's quite likely, isn't it, that we will get some pushback from NHSEI on our planning around some of those accessibility targets. But, you know, I'm personally confident that we've got a robustly derived set of proposals in our plan that are properly triangulated with our workforce. You know, so I'm up for having that robust debate with NHSEI when they come back looking for it. But I think from a board perspective, we just need to make sure that we stay focused on that kind of triangulation of, you know, our money, our workforce, and, you know, our planned performance trajectory, and make sure that we bring all of that together really clearly when we have future board discussions around all of this. And the IPR now helps us do that, and the kind of quality commentary that we've got in there helps us do that. Any questions for Chris before we move on to the next section of the report? Chris, have you got another comment that you want to make? Sorry.
Yeah, that's okay, Chair. Just commenting on bottom page 6 and over into page 7, which is the children and young people's eating disorder weights. It's just worth flagging there is that we're doing some work with our business intelligence team around how we report on that. So how we're expected to report externally is a 3-month rolling average, but what that doesn't capture is the in-month changes that happen as a result of targeted work. And so at the top there, it's referenced in terms of the in-month performance is 82% for routine weights and 100% for urgent weights, both against a target of 95. And so we're probably going to end up presenting 2 sets of data there in future, just so we can see that and track the changes of the work that we're doing, as well as what's reported outside external to the system.
Okay, Chris, thanks. That's helpful. Tim.
A very quick comment. I just wondered, I don't know if it would be helpful. So we've got a graph with the vacancies trend, and then there's a comment around staff in post, and I understand what it's sort of saying. I wonder if there's a combined graph that can show us the sort of relative movements, if you see what I mean, because I was just trying to get a sense of what the quantitative impact actually was.
I'm happy to come back on that if that's okay, Chair. So just on that.
Yeah, please do, Chris. Sorry, I'm struggling to hit the right button at the right time. Go on.
So that picks up again, I think, on your earlier point, Tim, in terms of how do we model some of this through, and in practical terms, it's quite different for different services. So we're focusing on our kind of priority areas at the moment, which those that are reflected in the risk register. So children, young people services and autism. And what we're trying to do is, which again will come through sustainability as the place to track that, is that we're modelling a trajectory, and that trajectory needs some challenge and confirming, which is the process we're just doing at the minute with our workforce colleagues, because we're saying from an operational perspective we think we can deliver that, but it's reliant on the assumption that we're going to recruit at a certain rate. And so we're just doing that sense check with Amy Beaton and the workforce team to say, what do you think is reliable in terms of prediction on workforce, and then our trajectory will match that in terms of operational delivery.
Thanks, Tim. Jane.
Sorry, Chair, I should have put that Chris has just made my point. I'm really sorry about that.
No, that's absolutely not a problem at all. Andy.
Thank Chair. Chris, I think the Chair has already referred to some of this, which is the triangulation of workforce demand and financial issues that we obviously will need as a board to have discussions about how we address those challenges. I guess the question I've got, which is an immediate one, what else would you need from the board immediately, Chris, to help support you with the work that you're doing on managing this on a day-to-day basis?
Yeah, thank you, Andy. I think the best thing for now is next month's sustainability committee. There's a number of reports coming through that are the trajectory work that we've built up around our particularly pressured services, and picking up the access tags and the conversation we just had around NHSEI and the expectations around that in terms of what we can and can't deliver. So a good, robust, challenging conversation around how we've reached those trajectories would be helpful, to make sure that we've put enough rigour into the process, and also then a conversation as part of that about how do we manage that expectation in terms of increasing access at a time when we've already got a number of vacancies. So we've got a good understanding and shared narrative that we can feed back to NHSEI would be helpful.
Thanks, Chris.
And I think if we realise the programme of board development sessions that I've got in mind, that will enable us to present some of that against a wider backdrop of what our ambition is for the organisation over the next 3, 4, 5 years, and it enables us to, map onto that our workforce constraints and forecast workforce constraints, and have a degree of rigour around all of that, which hopefully stands behind you in those conversations with NHSEI and others. And I don't underestimate how challenging some of those may be. Chris, grateful, thank you for that. We'll move on. I think Anita, you're next.
Thank you. As Mark said in his introduction, this is kind of our first go really at the quality section of the new IPR. What we've tried to do is, certainly for this one, whilst appreciative is work in progress, to pick up on kind of themes and questions that from experience I know have been important to members of the board. So it is work in progress. It will develop going forward. There's probably more detail in some of the explanations in this than there will be going forward, but just to kind of help with some of the overview. One of the first sections that we cover off is around complaints and complaint response times, which has been a key focus of it as previously. We can see from this report, and to be fair, probably whilst not ideal and not acceptable, understandable, some of the requests that have been made for extensions to complaints, the work that we've heard from, really the impact of Omicron, the closure of services, the redeployment of staff sickness. We have seen an increase in the amount of times we're being asked to kind of extend complaints. It does explain in here that we routinely haven't monitored the reasons for that, which we'll be doing going forward. At this moment is anecdote, but certainly, and I can kind of agree with that some of the information at the complaints department, because I'm getting involved in far more complex complaints that kind of are multifaceted and cut across many services. So they do are beginning to look more complex, but I think it's important that we start to log the reasons for the extensions. Had a very productive conversation with Chris and his associate directors around the complaints process and the requests for extensions, and the associate directors are very keen to be involved in almost approving locally those requests for extensions and making sure that we have a very clear triangulated process. So we are currently, as you can see from the paper, in regard to the actions that we're taking, we are linking in with the services. We are asking kind of why the extensions. We are trying to support far more from within the complaints department and the patient experience department. So really doing a detailed piece of work to address some of those issues. In terms of the patient safety section, the serious incidents, we've seen a decline in the last 4 months of reported serious incidents, but this isn't unusual. They kind of tend to go up and down, you know, it's probably not the best term, but we kind of do tend to see seasonal variation in terms of some of our RSI, so we are monitoring that closely. As I explained, there's probably a little bit more detail about some of the self-injurious behaviour that we're experiencing at the moment than we would have going forward in future reports. But I think just to help some of the non-executive directors understand some of the incidents that are happening in some of our inpatient wards. We heard earlier from Ananta some of the work that she spoke about in terms of Fiona Bone, the new suicide lead, who is also doing suicide and self-harm. And the staff are reporting some really positive feedback from that post, helping staff put some really clear protocols together around some of the very complex self-harm behaviours that staff on some of our inpatient units are managing at the moment. So we're doing a really detailed piece of work around that. I think in terms of this report, and Mark mentioned it in his introduction, around us really wanting to progress an integrated piece of work. What we're not able to do with the system retrospectively, but we've put very clear plans in place going forward. We know for all of us, and nobody more so than the staff on the front line in operational services, that, you know, the waiting lists and the growth of some of our waiting lists is really very uncomfortable and not a position we want to be in. However, at the moment with the demand, they're almost inevitable while we get on top of some of that work, but it's really important that we monitor sort of complaints, patient experience, incidents relating particularly to people on our waiting lists. So going forward, I've put a clear plan in place on how we will collate and collect that information. As I've said, it's impossible to do it retrospectively. It's not impossible, but it would be a very detailed piece of work. So, but it's something that we're looking at going forward that I'll report through this section. I won't go through every graph and every piece of information, but I've spoken about, and I spoke about it earlier when it was a question asked as part of the work around the electronic prescribing system, around the medication errors. There is a paragraph in there, and that will continue going forward. That will be a jointly written paragraph from the chief pharmacist and the deputy director of nursing around medicine safety and the impact of the electronic prescribing system on medication errors. And the final part of this report really that I wanted to bring to people's attention is around the safe staffing report. I presented the safe staffing paper earlier, but what is clear in this section of the report, we don't capture that firefighting feeling, and I think that was an expression used by Andy Spring at our last board meeting. And we heard a board story last time about some of the very difficult shifts that our staff are facing. And whilst that isn't every shift and it isn't on every ward, there are certainly periods and times on certain wards where it is incredibly difficult that as a board we need to be cited on. And it is purely a timing issue, but I have got a meeting next week with all the people that potentially have that information to bring something together. What I don't want to do as part of the integrated performance report is I could have a 30-page staffing presentation, and that isn't what I'm looking for, but we're looking for all the information that's available to us and seeing how we can kind of develop that area so that the board members do get more of a sense of the idea, the areas that are particularly challenged and have had challenging times. And in the desire to be integrated, we can hope that that will, you know, it may give us some of the integration around serious incidents, medicines errors, use of bank and agency from the people section. So there's a really detailed piece of work going on behind the scenes that the quality section is work in progress. I've got very clear vision on how I want it to look and where it's going, and I'm hoping it will develop month on month. But other than that, I'm happy to take questions.
Thank you, Anita. I think it's a really good start, and you know, for me, I've always wanted the IPR to be something that triangulates data with professional judgment. So, you know, bringing the kind of judgment that you bring to it based on the conversations you're having is as important as graphs and numbers in my book. Absolutely. I think just one point from me on complaints, Anita, if I may. This is a very personal view, and I recognise that others may not share it, but you know, chair's prerogative. So every now and then I do get to express a personal view. I'm much less bothered by how long it takes us to resolve complaints than I am about the quality of the outcome and how well we communicate with people while the complaint is being resolved. So, you know, if we have a choice between an extremely well conducted complaint with the right kind of outcome or a quickly resolved complaint with the wrong kind of outcome, I'd go for the former every time, as long as we take the complainant with us, you know, during that process.
And that's the bit for me, and that's the bit that I'm trying to work through. I agree, because usually you can tell when a complaint lands if it is going to be complex and intricate and need multiple services. What I want us to be able to do is identify that early on. So within the first week, we are saying this may be a long progress piece of work, rather than promising somebody delivery on a Friday and on a Wednesday we're saying, sorry, it's not going to land, you're going to need longer. That's not acceptable.
Yeah, so absolutely. And so, you know, I take some assurance from that, Anita, that our driver in this is quality and resolving the issue, not an artificially imposed timeline. And that's most important for me. I don't see any other questions or comments for Anita, so we'll move on. Thank you, Anita. We'll move on to the people section of the report. Jane.
Thank you, Chair. Jane Marshall, Director of Strategy. So page 18 of this document highlights our major concern that we've referenced several times already on the people agenda, which is around our vacancy rates. So this refers to vacant posts in the organisation, and colleagues will see the graph at the top of page 18 that shows that increase. Within those data, there is variation within teams in the organisation, and so we are looking at the variation that's created in different services below that overall trend, and that report has been once to the executive team and is due to go again. So we are looking beneath that overall level at individual services to see where we can act to reduce those vacancies. But it is a concern and it is a challenge to us overall, and I think we've rehearsed that to some extent during our conversations this morning. The second point I'd like to make is around the 2022-2023 plan in the context of that vacancy rate, where our plan indicates that we will increase over the next year the number of staff we have in post in our organisation. But as this report highlights, and as we've referenced during the discussion, due to further investment, need to address access targets and grow services, this impacts on our vacancy position itself. So we're not showing the same resulting decrease yet in vacancies, but we are planning to work over the next few months to reduce our vacancy factor. And I'll come back to some of the ways we are doing that in a few minutes. My third point is it's important for me to stress, I think, that We have worked hard on our dashboards, on our data, through really good joint working between our finance colleagues, the people team, operational teams, and our professional leads. And we are now in a position as an organisation to have access to robust data to allow us to tackle our problems on a recruitment and retention agenda. And these data being available have allowed my deputy, Amy Beaton, our finance colleagues and our operational colleagues to have the right conversations about what needs to happen to address some of those challenges. And we're starting to see the fruits of that coming through work that Anita Lewin, our Director of Nursing AHPs and Quality, described earlier when she spoke about safe staffing, through work that Dr. Ananta Dave has led around international recruitment of medical staff and new roles in the medical field. We're starting to see some of that benefit coming through. We're also looking, as we've described before, at international nursing and medical recruitment, refugee nurses coming into our organisations, rolling recruitment of healthcare support workers and new roles. And that is all really positive work that's going on now in partnership with our operational colleagues to tackle the challenge that we've got. In addition, as I mentioned before, we're looking at a whole suite of staff engagement around how we improve the staff experience of our existing people, but also think about how we attract more people in, and some great work going on around that. We're streamlining our time to hire processes, and we're working very effectively at alliance level and within our organisation to describe new roles, and our Director of Operations, Chris Higgins, is leading some of that linked to service need. And I think those offer real positive steps in the right direction, though that there is more to do as we tackle that problem. The final thing I wanted to just mention, Chair, is there is within this an opportunity for us to think differently about those groups of, I think, particularly graduates in some academic subjects who are available in as a potential supply of people to join our organisation. And we've come up with another proposal which we've worked in partnership with Health Education England on, which is at the bottom of page 18. We're currently scoping how we look at 4 new roles, additional roles coming into the organisation, but also we're doing a piece of work for healthcare support workers who may have been a healthcare support worker for a while and want to make their next step to maybe a band 4 role. So there's a great piece of work being led by Steve Skinner in our community clinical division, which is looking at a new health and wellbeing role, which will add real value, and we have support from Health Education England to do that. Thank you, Chair.
Thank you very much, Jane. Are there any comments or questions for Jane? It's just worth noting, isn't it, Jane, that all of our recruitment retention activity takes place against really in the context of a really challenging environment across the piece for recruitment of staff into mental health services. I read something I think earlier today or yesterday that something like a quarter of all nurse vacancies across the NHS are currently in mental health trusts. So we can't underestimate, how difficult the environment is against which we're working very hard. And I will also note, for the record, as it were, that I met 4 of our international recruits earlier this week, including our 2 refugees who are Palestinian who've come to us from Lebanon, and they were all 4 of them were an absolute inspiration, I have to say. And if we can clone them, that would be fantastic. I don't see any other questions or comments for Jane. So shall we move on then to who's picking up the next section? Are we back with you, Mark? Or
Yeah, we're back with myself, Kevin. Yeah.
Good. I knew I'd get there in the end.
Excellent, brilliant. Thank you. So I'm just going to do a quick summary of some of the financial sustainability headlines from our year-end position now. So this is the final position for the trust for the 21-22 financial year end. So as we've kind of picked up during the presentation of the report so far, it's really important that we make the best use of the finances that we have as an organisation to help stabilise services and team working really. So whilst on the face of it, we are reporting a year-end outturn of a £3.5 million surplus, which is £1.5 million less than we were planning. That's not driven by challenges within our service delivery model. This is purely the consequence of an unfortunate one-off kind of write-off that we've had to declare as part of our ongoing challenges around the Boston eradication of dormitory scheme. So whilst our business case continues to be reviewed and we're stress testing options associated to that, we're not able to carry on kind of reporting a capital investment until we have an agreed plan that we can allocate it to. So there is a one-off kind of hit in there of the 1.5 million, which is the entire driver for us being off target from a financial viewpoint really. However, saying that, although we didn't necessarily meet our financial targets as an organisation because of that, the system overall, we worked very closely with the clinical commissioning group and other providers in Lincolnshire to make sure that as a system for Lincolnshire, we did meet our financial targets. So we did end in a positive position for Lincolnshire in terms of our overall position, albeit different organisations at differing levels. And another good point to note really, eradication of dormitories aside, we were proven to have a good record of delivery of our capital investment for the year. So I think that's a really significant achievement both for LPFT and the system, given the hyperinflation that we're seeing and the challenges across the market and where we're at. So apart from the Boston scheme, which is the big driver for our negative variance on that, we had a good year end in terms of delivering our capital plan. The final bit I did just want to kind of pick up really, and it links into our entire conversation throughout board and certainly the IPR discussion today, is we remain heavily reliant on bank and agency use to support the vacancies that we have across our services. So we have kind of spent a significant amount of money on agency this year. In fact, it's the largest I've seen it, just under £3.4 million. That for me, from a financial perspective, gives me great cause for concern really, because whilst we're investing in non-recurrent agency staff, we don't have the stability that we want within our services. So all of the great work that Jane was talking around the recruitment pipeline and where we're going, we've reflected that within our financial plan for next year to help sure that we can make sure we've got the right posts in the right teams and we can deliver the best service we can without that reliance on agency. Just a final point on the agency as well. Whilst we've not had it for the 2 years during COVID, NHS England and Improvement have been very clear that they will start to be reissuing national controls over our use of agency. So I suspect this is going to be focused around not only our global total spend, but how much we will be spending on individual appointments and where we may be sort of paying in excess of agreed capped rates. So we don't have any detail on that as such at the minute, but I'll keep board up to date on that and the impact of that on our planning. But I think some of the great work we're talking about, certainly around the medical recruitment and what's going on with the team in there, hopefully that utilisation will reduce. So I'll leave it there from the financial sustainability element, Kevin, if that's okay. And just going through, I've been ticking off the discussions we've had, and we have referenced most of the key areas that we are potentially off target within our KPI indicator report on page 24. And for those that we haven't referenced, they are described within the metrics tracking table, which is on page 26. So we've picked up everything we needed to as a board today, I believe.
I'm grateful. I think you're right, Mark. I've been doing the same exercise as you. Tim has a question.
Thanks, Kevin. Mark, it's just a very quick one. So we don't know what the likely cap is on agency staff going forward, but when historically we had a cap on that, how does that compare with what our spend was in this last financial year?
Yeah, so our pre-COVID caps in was just shy of 2 million, and we've spent 3.4. So there is significant amount of reduction we need to work on that.
Yeah, thank you.
Thanks, Tim. Thank you, Mark, and thank you to colleagues for walking us through the IPR, which, as I think I mentioned earlier, I think is turning into a really good, comprehensive report that's got that right balance between professional judgment and data. It's my mantra. You've all heard me say it more than once. I'm more interested in insight than I am data, and we're getting some really good insight into this, and I'm really grateful to exec colleagues for taking the care and time to add their their judgment to this, because it adds significant value to the report. So thank you for that. Let's move on. Item 6.2, Sarah, is you, and there's a particular reason for this report appearing on our agenda, largely because there is a requirement, I think, for us to take it, given an understandable one, given the pressures across the system on ambulance waiting times. So not unreasonably, we are asked to commit a bit of time to this. So Sarah, over to you. I've probably now said everything that you were going to say. Sorry.
No, that's absolutely fine. Thank you, Kevin. So Sarah Connery, Chief Executive. So all the board members will either have been personally affected by current situation we find ourselves in with ambulance handover delays, or will have read some very tragic stories in the media about the harm that has been caused by such delays and continue to be. So, as I referenced in the Chief Executive's report, all systems under significant urgent and emergency care pressures. So this report is here for information. I will assume it's read as a system. In response to those pressures, we were asked to submit a sort of action plan where we are sit rep, what are our challenges and what we're going to do going forward around ambulance handover times. So the submission is there. It's been a request for this submission to come to all of the system trust boards. So it's there for information, just to highlight our alternative to the emergency department in terms of our mental health urgent assessment centre, which we got off the ground January, February time, is referenced there, and hearing some positive feedback from EMAS and other system colleagues, as well as our service users, in terms of the impact that that's making, despite us not even be at full capacity in terms of the recruitment to that area as yet. So I'll leave it there. It's there for information, but I shall do my best to answer any questions or comments that you might have. Thank you.
Thank you, Sarah. You're going to get a question, I'm afraid, from Sharon.
Hello, Sarah. Thank you for that. So I understand how we've developed alternative pathways of care to help divert or reduce admissions in relation to people attending A&E with mental ill health. I just wondered, in light of our own workforce challenges, whether we monitored as part of the work around this, how our own pressures, workforce pressures and mental health system pressures were contributing to delays in those transfers or diversions of care from A&E.
Thank you. I don't know whether Chris might want to come in from an operational point of view, but in terms of our business continuity plans, the two areas where we do divert staff in times of significant pressure are mental health worker in the police control room and also our crisis response vehicle as well. So it does have an impact. I don't know whether Chris is able to respond in terms of any specific data around that.
Yeah, we're not specific data, but just to say that it's time now. I'm just refreshing what we're calling the kind of short-term business continuity measures that really come into effect out of hours and over weekends, bank holidays and such. It's something we developed over the kind of Christmas break, and I'm just refreshing it now to share with the wider system. And it just shows the process we go to when we've got vacancies and absences at short notice, particularly. And so there's the usual process of bank agency overtime that we do to attract and incentivise people in, but beyond that then we start to scale back services, starting with those who have the least impact on our own patients in the wider system, and prioritising the most critical services, and for us that's our inpatient wards. And the sequence is really, as Sarah started to describe there, it's the nurse in the force control room that we can mitigate through our helpline and contacting other services. It's the crisis response vehicles that in essence are a member of staff in a forward focus that goes out, that we can divert into our new assessment centre instead and work with the police and telephone support. So we put mitigations in each bit, but ultimately it's worked up to the most critical end, that we have huge staff absences that were predicted at Christmas, that we step everything back to our most core critical services. But I'm just refreshing that, and I'm going to share that around with system leads probably this ahead of the weekend, so I'll have to share it with board members as well if that'd be helpful.
Thank you.
Thanks, Sharon. Thank you, Chris. I think it would be interesting to see that. Any other questions or comments? Is there specific action we need to take, Sarah, or are we just receiving this report?
Just receiving for information, and I think considering what may happen over the coming months in terms of ongoing pressures, then watch this space, because there may be further reports.
Yep.
Thank you.
Grateful, thank you. We'll move on then, if we may, to item 7.1, which is a report from the last meeting of the Audit Committee. Andy.
Thanks, Chairman. Andy Spring, Chair of Audit Committee. I don't want to prolong things. This is a very short summary of a 3-hour meeting. In terms of key highlights, I really would just like to commend the team, which I've already done in terms of Council of Governors, but I think I should do it at Public Board. Commend Peter and his team for the work they do in supporting the committee, and commend the executives for their responses to audit reports, in terms of their willingness to address the recommendations made by auditors as part of the report, the continued work of the Freedom to Speak Up Guardian, and of the, if you like, independent auditors, both internal and external, in terms of working with the organisation, with the trust to help us improve our corporate governance and broad governance. I don't think I've got anything else to add, unless other committee members would like to do so. The report really speaks for itself. So thank you, Chair.
Thank you, Andy, and thank you for an object lesson in concision. Managing to boil a 3-hour meeting down to one side of A4 is absolutely something we should all be aiming to be able to do. So thank you. I don't see any questions or comments for Andy, so we'll move on then to item 7.2, Board Assurance Framework. Peter.
Yeah, thank you, Chair. Peter Howard, Trust Secretary. The board will be aware that we actually took a copy of the Board Assurance Framework last month. So the only amendments within this one are in the quality section, because the Quality Committee has met since last month. There are 2 areas. One is Q1.1, which is the infection prevention and control, and the other Q1.3, which is impact of low staffing levels on safety. In both of those, the Quality Committee, having reviewed the information available, you heard of some of it earlier in this meeting today, have changed the assurance level to amber and put in place additional controls which are documented in the paper. And just one final point to make, that is that the some of the risk scores, as we heard earlier, are not aligned to the risk register. That's a quirk of time between the two documents being produced. What I will do is do a full refresh of scores between the two documents, which will come back again through the process, through audit committee and back to the board in July, which will be all tied back together again. That's all I need to say.
Super, thank you, Peter. I think the paper speaks for itself. Are there any questions or comments? I don't see any. So shall we move on then, Peter? I think the floor is still yours for 7.3.
Thank you, Chair. For the last 2 years, you'll be aware, everybody's aware that we've had to make changes to our meeting arrangements to implement the COVID restrictions and regimes. They are now easing and we are able to change our meeting arrangements. What the last 2 years has taught us is we are capable of doing many things online and in different ways than we ever thought before. What that's now enabled us to do is to look at a risk assessment for meetings that is broader than just infection control. And we've looked at this in terms of travel, cost, time, the environment, and balanced it also against culture, behaviours, teamwork, and human nature, to be honest. So there is a risk assessment attached to this paper, which I don't propose to go through in detail unless anybody has any questions. But to sum up where we've got to, this paper brings a proposal for how we should conduct board, council and committee meetings for the remainder of this year and suggests a further review in December 22, which would then be implemented in 23. So summing it up, we're suggesting that all formal meetings, which would be council meetings, board meetings and committee meetings, remain online unless there is a specific case-by-case need for it to be face-to-face or hybrid, and that we recognise the need for people to develop and maintain team working and culture, and therefore meetings that are meant to be developmental or that are meant to be discursive should move back to being face-to-face with suitable COVID regulation compliance, space, ventilation, etc., always allowing for a hybrid option for any at-risk individual who doesn't wish to be part of that, and that the executive team moves to a hybrid solution subject to room capacity. So that's the proposal, and happy to take any challenge or questions.
Thanks, Peter. Sarah.
Thank you. Yeah, I agree with the recommendations, but I think potentially one benefit that we're missing from the analysis, particularly around the sort of formal public meetings, is the ease of access. If members of the public want to join, so they don't have to find St George's, find somewhere to park and etc. They can just click a link. So I think that sort of needs to be factored in as one of the benefits. But just a plea that if when we come to do December, if not before, then that we do actually engage with members of the council of governors around what methodology they would prefer for meetings going forward. And again, it potentially might be a hybrid of virtual and face-to-face. Thank you, but thank you for doing the work, Peter.
Thanks, Sarah. Anita.
Again, thank you, Peter. And as you say, we're starting, and I support these. I think we've all kind of on this call have missed the opportunity to kind of get face to face, but it's important that we have a balance. You know, COVID hasn't gone away, but I think this allows us to do that. So I just want, I would ask for kind of lateral flows to be done before the face-to-face ones. I appreciate that's not always easy for those, certainly for Council of Governors members, and I'm not sure if they're entitled to the free NHS ones, but maybe we can have a bit of a look at that. But yes, I think it's important if they're on NHS business, maybe there's something so it would be a request for lateral flows before any of the face-to-face, certainly until that changes. For those of us in the NHS and our testing requirements, but other than that, I'm happy to approve that.
Thank you, Anita.
Comments being raised. Thank you.
Thanks, Anita. Tim.
Hi, thanks. Just a very quick comment on hybrid meetings, and I'm sure this is others' experience as well. I mean, I think pre-COVID, when you had hybrid meetings, there was always a risk if you were not in the room that sometimes it didn't really work particularly well. But the experience I've had in other forums around hybrid meetings is with the appropriate protocols, actually, you know, it can obviate that sort of potential risk of feeling a bit isolated by being down the line and not in the room. You know, there's some simple protocols that can be followed to make that okay.
Thanks, Tim. I was going to offer a comment before I come back to you, Peter, on hybrid meetings from a chair's perspective. I think we should avoid hybrid meetings wherever we can, and either do one or the other. My experience is that hybrid meetings are desperately difficult to chair, and being able to balance the input from people in the room and joining us down the line, as it were, is more challenging than it needs to be, actually. And you know, if we're in a situation where we think that for a number of people it wouldn't be safe to meet face to face, then we should just meet online, is my view. And while I've got the floor, as it were, I will just add to Sarah's comment. I think that we shouldn't underestimate the benefits in terms of the openness and transparency with which we conduct our business. The benefits of meeting online in that context are really significant, and for that reason, as much as anything else, I support the proposals, Peter, that you've brought. But sorry, back to you.
Just two points really for the record again. Firstly, we are investing significantly in high quality conferencing technology across a number of sites, which will help. And secondly, what I would be suggesting is any meetings held in public that we do move back into the room, we do need to invest in the recording technology to enable us to put that onto the website, and in some places we don't currently have that. So that's, as Sarah pointed out earlier, that transparency for meetings held in public. Doing it online is far more transparent.
Yeah, agree. Okay, are colleagues then content to approve the proposal set out in Peter's paper? Excellent. I think the answer to that is yes, Peter. Thank you very much. Let's move on then to item 7.4, which is mine. There are two recommendations here, well, three actually, that I'm seeking colleagues' agreement on. The first is to agree the appointment of Sharon as SINED, to agree the revised committee membership and chairs as set out in the paper, and to confirm the board's support for the Council of Governors' intention to appoint Sharon as the deputy chair. I'd be happy to take questions or comments on all of that, but if colleagues are content to approve those recommendations, with Sharon's exception, please indicate either yes or no if you take a contrary view, and we can have a discussion. Peter, you have a comment.
Very quickly, Kevin, just for the record, there's a typo on page 3. It's actually £2,000 per annum, not £2 per annum, as is.
Yeah, I thought that was remarkably stingy of us, but you know.
Apologies for that.
Excellent. Good. Well, thank you very much, colleagues, for approving those recommendations, and congratulations or commiserations, Sharon, depending on how you see it. We're nearly done. 8.1.
So, Kevin, yeah. Clearly, the venues are now confirmed based on the conversation we've just had. We will have in-person meetings for the Council, Governor and Board of Directors joint meeting on the 16th of June and in person for the 30th of June for development sessions. The rest will be via MS Teams. And if I can just flag on the 16th of June, at the end of the joint meeting, we do need the board to remain for probably only a few minutes, but it will be the formal sign off of the annual report that the extraordinary audit committee will have done that morning.
Thanks, Peter. That's noted. I haven't been notified of any other business. Peter, I don't know whether you have. So we have no other business. Thank you very much, colleagues, for contributing to what I think has been an excellent meeting, right from the patient story at the beginning and, you know, kind of high quality and constructive conversations right through to the end of the meeting. So, you know, thank you everyone for your engagement and for, you know, maintaining the quality of debate over and discussion over 3 hours. Thank you very much. It is now 12:05. I suggest that we reconvene for it in private session at 12:35. So we've got half an hour to go and get a cup of tea and a bun. Thank you very much, everybody.